And if you remember, the whole governance program was made by me in the last moment.
Yeah, yeah. Shall we start, sir? The 4 o'clock is now.
Yeah,
Yes,
ma'am.
absolutely.
Good afternoon, everyone. I'm Dr. Palpuri Lakshmi, Professor of Plastic Surgery, Usmania Medical College, Hyderabad. It is a great pleasure and honor to invite and welcome our patron, Dr. V. Bhattacharya, sir, and our overseas faculty and Zoom platform sponsor for this year, Dr. B. Venkatratnam Garu, and experienced teachers and experts in reconstruction of year. Our 4 panelists across the country for today's session, and esteemed 6 judges for this program across the country, and all Plastiquest faculty and PGs across the country for today's session. This is a unique competitive session in joining with the Apsicon 24. This is the Plastiquest competition in case presentations for PG students across the country. So far, we have conducted 7 sessions in Group 1, and today we are going to start the first session in Group 2. From each group, one team will be selected by the team of judges, and which will appear during Apsicon 24 in finals. So to get success in any field, we need hard work and dedication and sincerity. There is no shortcut for anything. And to get the success and good results, we need to pass various struggles. And many are self-made in our India, and few had the opportunity to go and learn from in foreign countries. And we have both the experts in our today's program. Dr. Bhandari sir, he's a Pitamaha in reconstruction of ear, not only microtia congenital anomaly as well as burn ears. It is amazing results which I had seen made out of his hands. And Dr. Uday Bhatt sir, he worked with me during the ear cartilage workshop, carving workshop, which I conducted at Usmania during NABI midterm CME. Along with that, 100 participants learnt the ear cartilage carving in that workshop, and he was a part of it and an active participant. And I was very happy in last Apsicon 23. Apart from getting elected as the EC member of APSI, and few told me that they, after attending the hands-on cartilage carving workshop, they have reconstructed the ear and got the good result. It gave me immense pleasure. So the workshop was conducted under the guidance of Dr. Nitin Mokal sir. He demonstrated, and Dr. Uday Bhatt sir helped, and a few faculty, Dr. Sudhakar Prasad and Ratnami and Raja Shanmuga Krishnan. We helped that PGs in carving the cartilage to the ear cartilage framework. Dr. Telag, he got trained under Fermin at Paris, and his reconstructed ears are really of near normal appearance and normal projection, excellent results. And Dr. Pavati is my colleague in the other institute, NIMS. She is a dedicated sincere teacher and now HOD of the department, and excellent. He does excellent job in ear as well as the craniofacial workshop. And we have great people with us to learn from them. There is no shortcut for any success, but we can learn from the experts in the field, and that definitely gives shortens our learning curve. But practice is the thing, and PGs will be benefited out of this session. I welcome Dr. all of you, and I welcome our co-organizer, Dr. Rohit, to give formal introduction of all panelists.
Thank you
And
so
we
much.
listen the success stories of each in the panelist time from them side.
Thank you so much, ma'am, for giving me this opportunity to introduce our esteemed panelists. Today, I'm the first and foremost panelist, the person who hardly requires an introduction, Dr. Pandari sir, the father of Indian rhinoplasty. He's now working as a consultant plastic surgeon at Max Smart Super Specialty Hospital, New Delhi, at Kailash and Kailash Deepak Hospital, New Delhi. And he is formerly consultant plastic surgeon, professor and head of the department, Burns Plastic Surgery Department, MAMC, New Delhi. He is ex-president of NABI and ex-president of Delhi chapter of APSI and ex-secretary of Delhi chapter of APSI. And he received state award by government of Delhi in year 2013 and 14 and DMA Visist Chikitsa Ratna Award by Delhi Medical Association in 2019. And he has delivered more than 250 guest lectures in various national and international forums. And to his name, there are more than 50 papers published in national and international index journals. We welcome you, sir. Thank you for honoring me. Hello. Ma'am, am I audible? Okay. Thank you, sir. Welcome.
Thank you.
Now I would like to introduce our second panelist, Dr. Uday Balakrishna Bhatt. Sir is a professor and head of the department plastic surgery at Topiwala National Medical College and BYL Nair Hospital, Mumbai. Sir has more than 30 years of teaching experience. And sir, to his name, he has various publications in national journals, most notable being the Nair Hospital Technique of Coastal Cartilage Carving. And he received R.N. Sinha Award for Best Publication in IGPS 2018 for research on nasal septum reconstruction. And he also contributed to the book chapter of a National Textbook of Plastic Surgery. And he gave Sundar Rajan Curation at ASurg 2021. He has been faculty at various national workshops and conferences. Sir's main interests are rhinoplasty and aesthetic surgery, and other interests are sketching, cartooning, and clay modeling. And he also delivered Sushrita Oration at Apsicon 2020. We welcome you, sir. Next, moving to our third panelist, Dr. Parag Dalam. Sir is consultant plastic surgeon and founder director of Designer Body Center for Advanced Cosmetic Surgery, Mumbai, India. He is alumnus of MAMC, Lokmanya Tilak Municipal Medical College, General Hospital, Mumbai, and he has done his fellowship in facial aesthetic surgery from Gent, Belgium, and also fellowship in ear reconstruction from Paris, France. As ma'am said, she is trained under Dr. Fomin and has several publications in international and national journals. Sir has contributed several chapters in several textbooks of plastic surgery and has been life member of ISAPS, IAPS, ASAPS, APSI, and MAPS. Sir, hobbies are like he likes to sketch, paint, and play tennis in his spare time. We welcome you, sir.
Thank you.
Now, the last but not the least, the fourth panelist, Dr. R. Parvati ma'am. She's been the professor and HOD of the prestigious Nizam's Institute, Hyderabad, and she has done her fellowship apart from an academic career. She has done her fellowship from Changwon Memorial Hospital, Taiwan, which is famous for micro and microvascular surgery. And she has been an academic observer at Manhattan, New York, USA. And her areas of interest are head and neck reconstruction, cleft and craniofacial surgery. Recently, she organized a workshop on craniofacial surgery at Nizams, and she has been lifetime member of APRAS, APSI, ISRM, and IAPS, and she has been reviewer of Indian Journal of Plastic Surgery. We welcome you, ma'am. Thank you for accepting our
Thank you.
request and being panelist. Now I'd like to introduce our students who are going to present today. They are Dr. Tanima Sharma and Dr. Sri Krishna Purak. Both are from Safdarjung Hospital. They are going to present a case of microtia, sir. Now I'd like to ask Lakshmi ma'am, please give a brief view of today's session, ma'am.
Thank you, Rohit. I welcome the PG team to present the session from Safdarjung, Tanima and Sri Krishna Prabhu. Today, the main case discussion is on the microtia. They will present in 10 minutes and this discussion will go on 40 minutes by all panelists or separately 10 minutes each. And followed by the PGs will ask, other team PGs will ask a question to the presenting team. So 2 minutes will be given to each team. And later the spotter for 10 minutes, instrument, X-ray, OSCE, counseling and operative session, documentation, each session for 10 minutes. 1 or 2 minutes before ending the time, the Rohit will announce. As it is a competitive session, I request the panelists to ask more questions so that the judges will note down which are answered and not answered and easy to give the marks. So the unanswered questions or contributions can be explained during the panelist session. After completing all the sessions, the panelists will be given 10 minutes each for analysis of the PG's presentation. So I request the PGs to start the presentation. Before that, Rohit will take the roll call for the all 14 teams.
Team 1, Madras Medical College. Are you there?
Present, sir.
Team 2, Jipmer Pondicherry. Jacob. Team 2, Jipmer Pondicherry.
Present, sir. Present, sir. Present, sir. Jipmer Pondicherry.
Okay, fine. Team 3, KGMC Lucknow. PGs from
Present,
KGMC.
sir.
Team 4, Stanley Medical College, Chennai.
Sir.
Ritika.
Present.
Hello.
Present.
Team 5, AIMS New Delhi.
Present, sir.
Okay. Team 6, Bangalore Medical
Yes,
College.
sir. Present.
Team 7, CMC Vellore.
Present, sir. Present.
Prashant. Team 9, RML New Delhi.
RML Delhi present.
Team 11, Kilpauk Medical College, Chennai.
Present, sir.
And Team 12, MAMC New Delhi.
Team MAMC present.
And Team 15, AIMS Bhubaneswar. Team 15, AIMS Bhubaneswar. PGs from AIMS Bhubaneswar. Team 16, AIMS Rishikesh. PGs from
Present, sir.
and Team 13 recently added. Like
No
NIMS.
need to announce recently added. They are already added.
Okay, madam. NIMS Hyderabad. PGs from NIMS Hyderabad. Nizams.
Actually, I think they are attending an exam. Probably they'll join soon.
Okay, ma'am. Sure.
At the time of questions, you can again ask.
Yeah,
Okay.
yeah.
About 14?
Sir,
The 2
14?
teams, actually, the first years gave the names for the
Yeah.
competition. Now they final years haven't joined them, so they withdrawn, sir. and NIMS joined as a final. We will share the new table to you today.
Okay, no problem. SRM. It was SRM, so deleted.
Actually, 3 teams withdrawn and 1 team joined.
Yeah,
So
yeah.
now we are having only 14 teams, 7 in each group.
No problem. Okay.
I request PGs from Saptajan, please kindly share your screen.
Ames Bhuvaneshwar has joined.
I am Bhuvaneshwar joined, ma'am. Yes, I saw the chat. Not in the chat box. PGs from Saptajan, are you able to
Share your presentation.
Yes, ma'am.
Wish you all the best. Present
Thank
well.
you.
Thank you, ma'am. Good evening, respected judges. I'm Dr. Sri Krishna and she's Dr. Tanima. We are team 8, BMMC and Saptajan Hospital, New Delhi. Our patient is Rakesh. He's 18-year-old male patient, shopkeeper by occupation. He's from Bijnor, Uttar Pradesh. He presented with chief complaint of deformity of right ear since birth. He's a second child born by full-term normal delivery, vaginal delivery, to parents married non-consanguinely. Age of the mother was 28 and father was 33 at the time of his birth. Antenatal history was uneventful. There was no history of any drug intake, radiation exposure, smoking, alcohol intake, or infection during pregnancy. The chief complaint was not associated with any other congenital anomalies. Developmental history was normal. He was well immunized in childhood. There was no history of hearing loss, difficulty in closing eyelids, or difficulty in chewing. There is no family history of similar complaints. No history of previous treatment taken for the same complaint. On general examination, patient is conscious and well oriented to time, place, and person. Patient is vitally stable. There was no evidence of pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Patient is averagely built and nourished. There are no syndromic features of face, and there is no evidence of cleft lip, palate, urogenital anomalies, cardiovascular, or skeletal anomalies. On clinical examination of left ear is normal in morphology and position. The length of the ear is 6 cm and the width is 3.5 cm. Helix, antihelix, tragus, antitragus, and lobules are well formed. External auditory meatus was present. Preauricular sideburn is present. On right side, the right ear was a small, vertically oriented remnant with the vestige cartilage. Lobule was present and vertically oriented and higher than the normal side by 4 to 5 mm. The external auditory canal is present. Helix, is absent. Helix, antihelix, concha, tragus, and antitragus were absent. There is a 0.2 into 0.2 centimeter skin tag present 1 centimeter anterior to the lobule. There is no preauricular sideburn. Preauricular sideburn is present and the hairline is normal. On local examination of face, face is symmetrical, chin is not deviated. There is no evidence of facial palsy, inability to close eyelids, or there is no deviation of oral angle of mouth. The occlusion was normal. Cant of dentition was normal. There is no epibulbar dermoid or no scarring over the face as well as in periauricular region. Superficial temporal artery is palpable bilaterally. Distance between the temporomandibular joint to angle of mandible is 6.5 cm bilaterally, and the distance between the edge of angle of mandible to the symphysis is 10 cm bilaterally. Chest circumference at the level of CP sternum is 91 cm. We perform a hearing test with 412 Hz tuning fork. The Rinne's test shows bone conduction greater than the air conduction in the right ear, and the Weber test, it was lateralized to right ear. It is suggestive of conductive hearing loss of right ear. So my diagnosis is Nagata lobule type right microtia without syndromic association and facial palsy. May I go ahead with the investigation and management?
Panelists, would you like to ask any questions now, or can they present the investigations also?
Please continue.
Please continue.
I would like to ask one question.
Yes, sir.
Why did you did the measurements of the distance between the external, the temporomandibular joint and the mandible? You wanted to show something?
Yeah, to rule out hemifacial macrosomia.
Absolutely fine. But any the measurements were also required, which will help you out in planning, which probably you missed.
Yeah, I have taken that measurements in the further plan of management. The measurement of distance between the lateral canthus and the root of the helix, and
That you have done, or you?
Yeah, I have done. I have done that.
You've
Sir,
done it.
They will tell in planning session, sir.
Okay, they will tell us in the planning session. That's
Yes,
fine.
Okay, sir.
Please continue.
So I would like to do routine blood investigation and pre-anesthetic workup. I would like to do audiometry and HRCT temporal bone just for documentation, and chest X-ray to know the costal cartilage ossification. My plan of treatment would be autologous stage ear reconstruction with costal cartilage with brain technique. I will counsel the patient and his parents that it would be a purely aesthetic procedure. It will not change his hearing capacity. So brain technique consists of 4 stages. The stage 1 is framework creation and insertion into the skin pocket. Stage 2 is lobar transposition. Stage 3 is framework elevation, and stage 4 is tragus creation, conchoid excavation, and autoplasty if required. So I will make a template from his normal ear with the help of X-ray film. Then I will take some measurements to make ear positioning template. So I will take measurement distance between the lateral canthus to the root of helix, and it is 6.5 centimeter on normal side, and from the alar base to the lobule, it is 10 centimeter. Then the inclination angle of the nose is around 22 degree, and axis of the ear is around 12 degree. So there is a difference of 10 degree. So I will mark the same measurements over the affected side so that I can decide the location of the new auricle. Then I would like to perform the surgery. Before that, I will ask patient to undergo laser treatment for hair reduction around the preauricular region of affected side. And before surgery, I would like to get the temporal region shaved. So I would like to perform the surgery under general anesthesia. So I will give a supine position to the patient, and with the neck slightly extended, and will paint bilateral ears as well as the right side of the chest for costal cartilage harvest. After dripping the patient, I will mark all the measurements on the face of the patient, and I will decide the location of the new auricle. Then I would harvest costal cartilage from the right side of the patient, and I will take slightly oblique incision so that I can harvest 6, 7, then 8 rib. So incision would be around 5 to 6 centimeter long. After taking incision, I will incise the fascia of external oblique and the rectus abdominis muscle, and will reach up to the anterior surface of the costal cartilage, and will create a plane over it. Then with the help of the template, I will decide the amount of cartilage that I'm going to harvest. So I will harvest 6 and 7 costal cartilage along with the zinc contrastes and the 8 rib. So I will take incision. I will like to preserve the. I will like to leave the posterior perichondrium behind. Then I will take incision along the edges of the rib, and will, with the help of periosteum, I will elevate the perichondrium, and will take out the 8th and 9th rib costal cartilage along with the zinc contrast. I will remove the 8th rib along with the pericardium. Then I will close the chest wound with, in layers, and will put a drain after putting a suction drain. So this would be the harvested cartilage, 6 and 7 cartilage along with the zinc contrasts and the 8th cartilage, 8th rib cartilage. So I will make a base plate from the zinc contrasts. I will have marked it over the zinc contrasts. So now I will carve the cartilage with the help of scalpels, 11 number and 15 number blades, and with the help of a bone gouge. I will make a base plate which has the anti-helix and the part of the helix and the antitragus. Then with the help of 8th rib, I will cut the 8th rib longitudinally and will fix it along the upper pole of the base plate to form helix. This would be my marking this would be the green color shows the incision line, and it should be a vertical incision in front of the vestige, and the red color shows course of the superficial temporal artery that I will not disturb. Then I will take an incision, will create a pocket 1 to 2 centimeter larger than the framework, and will insert the after achieving proper hemostasis, I will insert the framework with the lower pole first, and then followed by the upper pole. Then I will close the incision, and will after putting the suction drain, I will put 2 suction drain, one behind the helix and one beneath the framework in the conchal region. After applying section, I will see the contour of the ear and the skin envelope. Then after that, I will give a light dressing to the area. Post-operatively, I will ask patient not to lie on his operated side. I will check for the skin vascularity, color change, or erythema on post-op day 1 by a small window dressing. I will do post-op dressing on day 7 and will remove drain by 7 to 10 days. I will also ask after discharge, I will ask patient not to do heavy exercises for 6 weeks, and he can resume his duty after 2 to 3 weeks. Thank you.
They completed their presentation in 10 minutes. Panelists can discuss now.
Madam, can we go back to history because I missed it, the initial first?
Yes, sir.
Yeah.
Yes, sir.
So, Shri Krishna, good afternoon. Please go back
Good
to the first slide.
Yes, sir. So he's
Yeah.
chief complaint, sir.
Yes.
He's an 18-year-old male patient.
Yeah.
His
Yeah.
chief complaints
No, no,
is
just
deformity of
run
right.
through. Just run through. I will tell you to stop when it. Just run through. No family history. You just go back. You said there is no family history. Go back. Yeah. There is no second second bullet is
Yes,
no
sir.
family history, right? So what is
Yes,
the
sir.
significance? Why are you asking for family history in case of microtia?
Sir, microtia of 20 to 60% of cases of microtia are associated with the syndrome. There are 18 recognized well-known syndromes that are associated with the microtia. So to rule out that, I asked about family history.
Are they known to occur more sporadically, or is it they are familial? What is the more?
So sporadically.
Okay, they are more sporadic. Okay, but of course there is no harm in asking a family history. Secondly, there is no history of hearing loss, and if there is history, is there history of hearing loss or no history? There is no history, no?
He's not complaining of hearing loss.
Okay, if supposing there is history of hearing loss, then what will you do? Supposing there is a history of hearing loss on that side, what will you do?
We'll have to rule out sensory neural hearing loss
whether
as
it
well.
is sensory neural or conductive hearing loss.
Because conductive hearing loss can be compensated for by the other ear as well. But in if the patient, we have to rule out in this case if the patient is having sensory neural hearing loss.
Yeah, patient has conductive hearing loss. Okay, that is confirmed. So what will you do? There is loss of conduction. What can be done? Or what should be done rather?
In this scenario, we will not do anything because
very
he has already achieved
very good.
normal hearing.
Very good. Please continue.
Okay, so in case.
Yeah. No, come to your examination now. Go ahead. 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 Chest circumference. Okay, go back. Go back. Go back. Go back. Why did you take chest circumference at the level of zipisternum? What was the reason for calculating this?
If I'm going to do perform Nagata type of ear reconstruction, for that the chest circumference should be 60 centimeter as per his.
Yes, but here you are describing some other thing. You are describing Brent.
Yeah. So this is I have done just for documentation. If I change later on, if I change my plan, then I should have some.
Okay. What is the relevance of chest circumference?
Because Nagata he used to create a more 3D bulky ear framework, which requires more amount of cartilage.
Yes, that is precisely my question. If you have an option of 3D reconstruction, then
Yes.
why are you sticking to your old-fashioned 2D reconstruction? Of course, I have nothing against brain type of reconstruction. It is supposed to be very good, but I think it has become little anachronistic. No, it is two-dimensional. You agree with me or no?
Yes, yes, I agree with you. But
So, what is the reason for choosing that option?
We are familiar with this technique, so that's fine.
All right. So, if you are familiar, if you have seen it being done, what is the age at which you do it?
Brain type of reconstruction can be done at 6 years
Six
old.
years, starting from 6 years of age.
Okay. And how many stages? How many stages do you require for brain?
Four stages.
And how many stages do you require for Nagata?
2 stages.
2 stages. All right. So you are having patience. No harm in so long as you deliver the result, it is okay. Brain is still a very good technique. I have nothing against it. If you are choosing brain, you should be able to execute it. You should know how to do it. Okay. So what are the 4 stages of brain? Can you describe the stage?
Yes, sir. Stage 1 is a framework creation and the creation of pocket and insertion of the framework into the pocket. Stage 2, it will all the stages are done with the 3-month interval. Stage 2 will be a lobal transposition with the Z plus T. Stage 3 will be framework elevation and thickness skin grafting on the raw area. And stage 4 is the conchal excavation and creation of tragus.
Very good. With regard to the incision, is there any difference between Nagata technique and brain technique? And what is the difference and what is the significance?
In brain technique, we take a anterior vertical incision. In Nagata, we take a W-shaped incision. And Nagata transpose lobule at the first stage itself. So with that W-shaped incision,
it can be transposed in the first stage itself.
Very good. Bandari sir, please go ahead.
I have a question over here. The chest circumference is important at what age? This patient is already adult. So is it actually required to measure the chest circumference at this age?
No, sir. It is required for pediatric patients.
The other question was, what was the right age, the earliest age where you can start reconstructing the ear? By what age ear is normally developed, almost adult size is grown?
At 6 years of age, ear is within the 6 to 7 mm of the normal.
Around 90% of the adult ear size.
6 years is too young age. I believe 8 to 9 years is the time when 90% of ear is grown. And especially in Indian scenario, 6 years is a person is too young to undergo for ear reconstruction. Because if you compare Westerns, the Caucasians, 6 years child is very stoutly built, the height is good. In our scenario, 6 years is too young to start ear reconstruction.
Okay.
So usually in our scenario, in our country, we usually start after 10 years of age, and 6 years is too young to start ear reconstruction.
Okay.
And the other difference between the Nagata and the brain, when you're taking out the cartilage, what is the difference when you're taking out the cartilage?
We take
Brent and Brent prefer
horizontal. The difference between Brent and Nagata?
Yeah, Brent and Nagata, they usually prefer horizontal to slightly oblique incision, and the Fermin takes oblique incision along the costal margin. In Brent, Brent used to harvest 6, 7, and 8 cartilage, and Nagata used to take 6, 7, 8, 9, and sometimes 10 cartilage, and Fermin harvests 6 to 9 cartilage. In Brent, he harvests extra perichondral harvest of the cartilage, costal cartilage. Nagata used to leave behind entire perichondrium, and he used to place remaining pieces of the cartilage back into the pocket, so reduce the chest deformity. And Fermin, he used to take only anterior perichondrium, leaving behind the posterior perichondrium.
Absolutely right. The Nagata will do subperichondral dissection, make the pocket and put the cartilage back, whatever is left behind, so they get consolidated and they avoid this deformity. And of course, the dent will take only 6, 7, 8. What farming does, Dr. Parag will able to tell you what else she has a different classification also for the ear cartilage for the reconstruction of the ear. Yeah, Dr. Parag.
Yeah. So, are you aware of the Fermin classification?
Yes, sir.
So, in the Fermin classification, what would be the approach that you will have for this particular patient?
For incision?
Yeah.
Yeah, I would like to take type 2 incision. That is transfixion incision in this patient.
How will you decide whether to take a type 2 or a type 3B?
You can take in type 3B if there is no properly formed lobule and only vestigial remnant is there, then I will go for the type 3B incision where there is skin deficiency also.
So how do we decide about that? How do we decide about the incision?
If you have a lobule, then I would like to do transfixion incision, and I will do that will also help in transposition of the lobule at the same time during first stage.
You have to make a pattern of the opposite normal ear and place it on the side where there is microtia, and that you will then be able to assess the deficiency of the skin.
Yes.
If the patient has a low hairline, what would be your approach to this patient?
If a patient has a lower hairline, then I will ask patient to undergo laser reduction of the hair over the pocket position, and then I will perform the procedure.
Is there anything else that you can do?
If it is more than 1/3, like if it is if the hairline is present only in the upper
over
one,
the helix, then during second stage we can put TP fascia also and remove that part of the
hair bearing skin. You can use TP fascia for cover.
That's correct. In your history, you mentioned that you have asked for previous treatment. So how does any previous treatment affect your plan?
If he has undergone previous ear reconstruction attempts of or any then it can compromise the future reconstruction option like TP fascia. If there is a damage to the superficial temporal artery, then we won't be able to take the TP fascia for the secondary reconstruction.
Are there can you name some syndromes that are associated with microtia commonly?
Sir, Tricher-Collins syndrome and craniofacial microsomia. Then Nager syndrome and Chart syndrome.
Downey-Brock syndrome.
And golden hair syndrome.
Is there any other test that you do as a part of your systemic examination in children with microtia?
We have to rule out other congenital anomalies.
Like
we can do
cardiac,
USG,
cardiovascular system and examination.
2D echo and ultrasound abdomen.
Ultrasound abdomen to rule out urogenital anomalies.
That's correct.
Also.
That's it.
Dr. Krishna, and you have asked about antenatal history. How is it relevant? Any significance in the antenatal history? Can you go back the slides in the history?
Yes, ma'am. Ma'am, drugs like isotretinoin, promethazine citrate, and thalidomide intake, if there is during the pregnancy, then it can cause microsomia. As well as there is, if rubella is there in the first trimester of the pregnancy, it can cause microtia.
Okay, good. Okay, come next slide. And about the family history, is there a risk of hereditary dominance? What is the relevance?
In this case, it is a unilateral case, and it rarely runs in families. So there are less chances if it is
associated with syndromes. When that times many of these syndromes are autosomal dominant, like Tricher-Collins, it is autosomal dominant. And if associated with microtia, especially bilateral microtia, then we'll have associated family history.
If there are 2 children associated with microtia in a family, what is the risk in third child? Is a percentage given? Any risk is allocated for that? It is important for the counseling. There is a risk given about 15% for the child if two children are affected in the same family. That is one thing. History of hearing loss. Okay. Previous treatment. Treatment about the previous treatment. You can be specific about what previous treatments you could have asked. One is about the scar. The other thing is
if the patient has any bone hearing, bone anchoring hearing aids.
Yeah.
So they if they
Atresia surgery,
yeah, you can
that will or any
it will cause scarring in the peri-auricular region, which may hamper the
so
creation.
it will be difficult to
Yeah.
create a
implant.
You can mention that in the history. Next slide. Okay, no syndromic features of the face. Okay, you have mentioned any association with cleft palate, urogenital anomalies, and any percentage, what percentage you can attribute to the involvement of these systems? Do you have any idea? Associated with
30%
cleft
association will be there with the cleft lip palate and cardiovascular.
30%. It is too high.
Yeah. And 15% with the skeletal vertebral anomalies.
No. Urogenital anomalies.
Urogenital and cleft lip is 30%.
It is not the skeletal anomalies are more, it's especially the facial anomalies. It is about 30%, whereas palate and urogenital anomalies probably around 4%. I think cardiovascular about 2% or something. Next slide. Okay. Okay. Next slide. So what are you going to do the preauricular tag you have mentioned?
Yeah, we'll exercise it during first surgery only.
Is away from the incisional lines. Okay.
Yeah.
Next slide. And you have not mentioned the discrepancy about the lobule compared to the normal ear.
So I have mentioned it. It is a slightly 4 to 5 mm lower than the 4 to 5 mm lower than the higher than that of normal.
Okay, did you take the measurement and incorporate it into your planning? I didn't see it in the planning picture where you have drawn it. This one.
Yeah, it is slightly lower than the.
It is corresponding to the lobule. You have to take extra additional 4
Yeah,
to 5.
I have taken extra.
Green line is
it's not depicted here. That's why I'm asking you. Okay. Yeah, I could see now. Okay, fine. Go back. Fine. Okay, next slide. Fine. Next slide. What? Next slide. Okay. What other classifications you know, and how do you classify the microtia?
Ma'am, there is a Tanzer classification. The type 1 is anosia, type 2 is a microtia, that is complete hypoplasia of the ear. It has been divided into A and B. A is without with atresia of the EAC. B is without atresia of the EAC. 3 is hypoplasia of the superior 1/3, middle 1/3. 4 is a hypoplasia of the superior 1/3. It has 3 parts. First is the constricted lobe and cup ear. 2 is the cryptotia, and the 3 is the complete hypoplasia of the superior 1/3, and the 5th type is the prominent ear. There is one more classification, the robust classification. It has 4 types. First is the microtia, second is the lobe ear, which involves only helix and scapa, and the third is the cup ear, which involves helix, scapa, as well as the helix and helix, and the fourth one is the anosia.
Next. HRCT of the temporal bone. Why do you need HRCT of the temporal bone? Any reason?
Just for documentation purposes, in HRCT temporal bone, we can see the continuity of the ossicles as well as
status of the middle
status of the middle ear, space of the middle ear, patency of the oval window, presence of stapes, pneumatization of the mastoid.
Is it associated with an internal malformations, internal ear malformations?
No,
No,
no, not true.
because internally developed from some
From
ectoderm.
ectoderm.
I've asked for chest X-ray for costal cartilage ossification. Is it more relevant with chest X-ray or with the CT scan?
CT scan will be
Be
more
more-
sensitive.
Yeah.
Uh,
Chest X-ray you'll not be able to identify. Chest CT scan is a better one to see the ossifications. Most of the times I have not seen till now. So when you are planning reconstruction in adult, he's 18 years. Do you expect any calcification at this age? What difficulties you face?
Actually, ossification starts after completion of the puberty. So there are chances that I can get partial ossification of the costal cartilage, but it is not always constant. It can be variable depending upon the different states.
How do you overcome that?
If I find ossification of the cartilage, then I will use burr and the bone drill to
Carve
carve
the
the frame, and I would like to carve the. If there is complete ossification, then I would like to carve a single framework with the different.
Does it have any implication on outcome?
Yeah, the year will be harder, and there as we are not, we will only be able to give. We will won't be able to carve it properly. There are chances that the new auricle will have less curves than the cartilage.
May be difficult to bend it, but you'll be able to do the carving and get the shape. But with relevance to the resorption, is there any significance?
If we are using the power tools such as drills and all, they may have an impact on chondrocyte viability. So they may cause damage to chondrocyte. So chances of resorption may be higher since we are causing damage to chondrocytes.
May I ask Dr. Bandari, sir? In elderly males or females, whatever, if there is a ossification using the burrs and all those things, does it influence the outcome? Any resorption?
Initially, it will definitely have the outcome in the result because you can carve out the base plate with the burrs, but it's extremely difficult to bend the ear cartilage for the helical reconstruction. And the beauty of ear reconstruction with the helical and the anti-helical margin. So it is extremely difficult to bend the ear cartilage to make the helix. Base you can make still with the burrs and chisel and hammer. And definitely there are chances of resorption if it is ossified because you're doing with the burr and the cartilage survives by diffusion. The bone has to integrate, means it has to survive by creeping substitution and osteoinduction. So that will make the sense that there are chances of resorption if it is ossified. Then it becomes your rib. It is not costal cartilage. And the free bone graft will survive by creeping substitution and osteoinduction. So the chances of absorption are definitely more.
Thank you, sir. And is there any specific length which you look for when you're carving for the helical rim, the minimum length?
It should be at least 7 centimeters.
Yeah, ideally it should be around 10 centimeters to have full from root of helix. So 8th rib, I'm not sure, but definitely free floating ribs probably will give more length.
Yes.
Next slide. Okay. Why did you specifically choose brain technique? Any specific reason in this 18 years child? Lobule is well formed.
Yeah, ma'am. Lobule is well formed, and the patient is also adult patient.
And
ossification chances will be higher. So Brent has 2D framework, so there will be less requirement of carving.
You have adequate cartilage. You have good tissue, and elongated tissue. Vascularity should not be a problem. You can directly consider for Nagata technique. Any reason why you have specifically chose Brent technique?
We have seen Brent technique in our hospital, so that's why.
Next slide. Okay, next slide. Next slide. Regarding the skin thickness, the plane of dissection for the skin pocket and the extent of skin pocket.
The skin thickness should be at least 2 mm as per Nagata. There should be a thin layer of fat beneath the dermis, and you should be able to see the light thrown in the pocket, torchlight thrown in the pocket. You should see the illumination. And in terms of extent, it should be 1 to 2 centimeter larger than the ear framework.
The marking doesn't show the extent. It is in the next slide. I didn't. I think probably it is the next slide. Okay. How do you fix the helical rim and base plate?
Ma'am, I will fix it with the nylon 40 or Prolene 40.
Okay. And you're talking about the otoplasty on the opposite ear. What exactly you're planning to do?
In case of if there is a discrepancy in the shape of the bilateral ear, new form ears, then I can adjust the opposite ear according to that.
How do you do the tragal reconstruction?
I will take a J-shaped incision with the vertical limb of the J along the posterior border of the feature tragus and the crook of the J in the intertragal notch. Then I will harvest a contracutaneous graft from the opposite anterolateral aspect, and will put that graft in that space by removing some tissue under that skin.
Have you seen?
So, sorry?
Do you do regularly? Have you seen the results? Because I don't use that technique.
Yeah.
Can I interrupt over here? For examination point of view, what he is saying is absolutely right.
Correct, sir.
The brand does this, but I don't think any one of us is using this technique because it's extremely difficult for a composite graft to survive. So it is always better to carve tragus and antragus with the cartilage itself. Maybe in the last stage, prefer to do in the first stage, as Dr. Bhatt said to you. Nothing against brain technique, but if you are constructing the antragus tragus in the first stage itself, that helps you out in reconstructing the ear. So it is advisable to reconstruct the antragus and tragus with the cartilage itself.
Yeah. Okay. I just wanted to bring out that point. Thank you, sir. Any other technique for tragal reconstruction?
As Nagata and Fomin they do, we can carve the tragus and antitragus in a single piece, and we can put it. Sorry, Nagata used to carve tragus separately, and the Fomin used to take a U-shaped piece of cartilage to reconstruct both the tragus and the antitragus.
Any other technique? There's another technique which uses chondrocutaneous flap from the same ear, same concha, folded and used for tragal reconstruction. That is also one technique. Okay. I think.
No, I have a couple of questions, madam, if time permits. I have a couple of questions, if time permits. Hello.
Yes, sir. Yes, sir. There is time you can ask.
Sri Krishna, in your antecedent history, you said that you asked about thalidomide. Why?
Yes, sir.
Why did you ask about thalidomide?
It is associated with the micro.
I know, we all know it is associated, but where is the question of thalidomide consumption come in the first place? Is it available? Is it manufactured? Is it banned?
No, no, sir. It's not.
So
yes.
It is being stereotypical that asking history about thalidomide is no longer available.
Yes, yes.
Yeah, that is one. Secondly, what is the difference between microtia reconstruction for this case and reconstruction in Treacher-Collins syndrome? Are they the same or there is some difference?
No, sir. Treacher-Collins syndrome, the face will be of a smaller size, and we have to reconstruct a smaller ear than this case. And
Also
there will
the
be a
hair-
bilateral involvement of the ears.
Hairline will also
In the Treacher-Collins, there will be a low hairline. And there are chances that the patient can have a coronal scar at the region of the TP fascia. And a patient
Fine. In hemifacial microsomia, is there any difference?
Yes, ma'am. So in hemifacial microsomia, the hairline will be low, and there is a soft tissue and the bony hypoplasia that we and it is associated with the
Abnormal course of facial nerves.
dystopia of the vestige. It will be placed anteriorly and inferiorly, sometimes in the face mark. If you reconstruct at the same place, then it will be in the face mark, and it can be associated with the ectopic superficial temporal artery.
So what do you do? What is the difference? What do you do when you're reconstructing?
So we have to we have to place the auricle just behind the somewhere between the
No, before that you do something.
So for hemifacial microsomia, we'll first have to we can go ahead with mandibular destruction also.
Yes, very good.
Mandibular destruction, we have to
achieve
The
symmetry.
bony platform has to be set right. Yeah, that is the answer that I wanted. Thirdly, you said this is autologous reconstruction, correct?
Yes, sir.
And we always reconstruct like with like. Okay.
Yes, sir.
So do you think this is the ideal way? Is this like for like reconstruction, or
It's not a
Not
like
so-
for, but if you use the elastic cartilage of like opposite ear, then it is very thin and pliable cartilage. Then it will flatten over the period of time, and there will be loss of definition. So that's we take a harder cartilage.
all right? All right. Thank you.
Thanks.
Can I ask one more question?
Yes, ma'am.
There is 10 more minutes time.
Okay.
So you can proceed with questions.
In facial skeletal anomalies like craniofacial microsema, hemifacial microsema, what age do you want to reconstruct the ear? Is it the same age or?
Because the patient will have to first undergo through achieving symmetry of the other side, as in the mandibular distraction, and correction of the bony framework. So obviously the reconstruction of the ear will be at a later age than the usual.
So
we'll
what
start
age?
I will do bony and the soft tissue correction first, and then I will go proceed with the ear reconstruction.
Bony and soft tissue reconstructions at what age, and then the ear reconstructions at what age?
Sorry.
Ma'am,
Bony reconstructions at what age, and ear reconstructions what age?
ma'am, if the child is having airway problems at an earlier age, suppose the child is having micropneumonia or retropneumonia, then we can start distraction even at a younger age, mandibular distraction, so as to achieve adequate airway and prevent the tongue fall. And then once the patient, after achieving adequate distraction, then at a later age, when the patient achieves as in around after 8 years of age, when the patient has adequate cartilage available, then we can go ahead with ear reconstruction. But mandibular distraction we can start at an earlier age also, so as to have adequate airway.
If the child comes at around age of 10 years, how will you proceed? Teenage.
Ma'am, we first have to counsel the parents that it will be a multi-stage procedure. And then we'll do the adequate workup of the patient, take CT, do the CT scan to find out the deficit in the height of the ramus and the
No, I want
body of the mandible.
Okay, how will you proceed? Whether
ma'am.
the skeletal ones or with the ear reconstructions? That is what I wanted to know.
We will proceed with the skeletal
Skeletal
reconstruction
only
first. Otherwise, we won't be able to decide the exact position
Exact position of the ear framework. So we'll go ahead with bony reconstruction only first.
Generally, if it is a teenage, I think we'll wait for skeletal maturity and go ahead with reconstruction with approximate calculations. Then, I mean, even with the distractions and all those jaw surgeries, it is not the final occlusion and final stable segment. So we might have to, I mean, there might be a recurrence of bony deformity. So it is, I think we can wait further till the child attains the skeletal maturity and do the final skeletal corrections. So in that case, probably we can do approximate calculations and do the ear reconstruction, go ahead with the bone skeletal corrections at a later age. What is the problem in these deformities? It is not only positioning, there'll be a lot of soft tissue deficiencies. So the projection of ear is
Yeah, there
not,
could be hypomastoid bone required extra projection.
Yeah.
Suppose you have had, you did the autologous reconstruction, and when you open the dressing after 3 days, you find that the skin has turned blue. How will you manage this case?
The entire skin.
Yeah.
The first, if the completely.
So depending upon how much of
the
skin has turned
discolored,
discolored.
depending upon that, if it is smaller piece, then we will do daily dressing, and if it is more than 1 centimeter, then we have to do flap coverage from the peripheral area.
Will you start any medications?
We will start with the antibiotics that we are already giving, and if there is if the drains are in situ, then we will give antibiotic wash, and if there is complete skin necrosis, then we'll proceed with the TP fascia coverage.
We'll wait for demarcation first, and then
we go for the.
Yes, sir.
What local flaps can you consider depending on the size? Small defects.
If it is anteriorly, then we can use a preauricular flap, or posteriorly, then along the helix, you can postauricular flaps. If that is in the middle, then we have to go for the local fascia flaps.
So how do you do this third stage?
In third stage is a framework elevation. Then we take a incision approximately 4 to 5 mm away from the helix, and we make a plane so that some amount of tissue should be there adherent to the posterior surface of the cartilage. Then we will create a plane up to the concha. And Brent usually don't put any cartilage block, but we will put a cartilage block so that the projection is maintained. And to cover that cartilage block, we will take a mastoid fascia from the occipital region, and we'll cover that. And it will be covered with the split thickness graft.
So you're putting the graft over the posterior surface of the elevated ear and also on the mastoid region.
And the surrounding skin, I would like to advance to decrease the raw area.
Okay. So to take the cartilage again, you have to open the chest.
No, we will bank the small amount of cartilage in the preauricular region or in the chest.
You have not mentioned it in your plan.
Yes, ma'am.
So if you are planning for that, you have to bank it somewhere, either in the chest or in the scalp. So that you have to mention it in your plan also.
Okay.
Why do you want to preserve the cartilage in the preauricular region? Why do you want to deform that area? Keep it in the chest, in the appearance tissue.
Yes, sir.
Yes, sir. And what is the difference when you are elevating with the Brent's, with the Nagata's technique or Furman's technique in the second stage? What do you do in Nagata's technique in second stage?
In Nagata, after elevation of the framework, he put a costal cartilage graft, and then he'll cover that entire area with the TP fascia. he determines the surrounding skin also, and he will put TP fissure like Western band fashion, and then he will put the graft over it. So,
I want in clear terms, you elevate the reconstructed ear, then you want to keep it elevated by putting something behind it.
yeah.
So you want to, and you have not saved that cartilage in the first stage. So you'll go back to the chest again in the Nagata's technique.
No, we have to bang that cartilage in the chest incision or in the post-auricular region somewhere.
No, in Nagata also, he is saving the cartilage in the chest. And the Furman's technique also, they are saving the cartilage in the chest in the first stage, or they are going to harvest the cartilage again in the second stage.
Furman saves the cartilage in the chest incision, and the Nagata sometimes he harvests it again.
Nagata will harvest it again, fifth costal cartilage.
Fifth or opposite side costal
cartilage. Put the cartilage behind at the level of anti-helical margin, and then cover the whole area with this superficial temporal artery flap.
Yes, sir.
And then put a graft over it.
Yes, sir.
And Dr. Parag will be able to tell you the what she does, the Furman does in second stage. She will not use the temporoparietal facial flap.
No, in second stage, Furman plus she elevates the. There are 4 techniques she has described in her book, but what she follows is the mastoid fascia flap. She covered it with the mastoid fascia flap, and that mastoid fascia flap only covers the cartilage block, and then she covers it with the split thickness graft. And the second stage depends on the result of the first stage in Furman, because she keeps the projection pieces below the root of the helix and the tragus, as well as in the antitragus and the antitragus and antihelix. So depending upon the projection required, she performs the surgery.
So I'll tell you, when you're elevating the reconstructed ear, you might inadvertently expose the cartilage on the posterior surface. So if you're using a temporoparietal facial flap, this can cover everything on the posterior aspect, including the cartilage which you have put in for elevation. But if you are taking mastoid fascia, sometimes it may fall short if the cartilage is exposed. But still, mastoid fascia can also cover the area if it gets exposed, besides the cartilage piece which you are putting behind. So either a mastoid fascia or temporoparietal fascia can be used to cover the cartilage in the second stage or third stage of dents and put a thick splitting graft after that.
Yes, sir.
Sir, we are done with the time which was allotted for the case presentation panel discussion.
Time is over now.
One more
Time is over.
Last question, just to complete the examination. How about the lobule reconstruction for this case?
I will. In second stage, we will take a Z plastic.
If it is not there, what other methods
of lobule reconstruction?
Yeah, just for the
there are different methods like Gentino, Irenis, Davis method, Converse, Brent method. Any technique we can use if lobule is not there.
Okay.
So of course there are different techniques, but it is always better to incorporate cartilage for lobule reconstruction also, because other techniques, they will never give you a good dose for lobule reconstruction. So especially in male like this patient, you can incorporate a cartilage because he's not going to have tops or something like that. So you can incorporate cartilage for lobule reconstruction also, especially in males in the first stage itself, if there is no lobule present over there.
Okay.
Now, for PG's questionnaire session, other teams, the PGs will ask question to the presenting team. 1 question for each team, and 2 minutes will be given to them.
Now, team 1, Madras Medical College.
Good evening, ma'am. Can you enumerate the stages of Tanzer method of reconstruction of ear?
In Tanzer, used to do lobal transposition during at the time of the first stage only.
How many stages are there in Tanzer, and can you enumerate the stages?
Sorry.
You have to answer.
Yes, ma'am. There are 6 stages. The first stage is lobule transposition. Second stage is cartilage harvest and framework creation. The third, they create the tragus. Fourth is elevation. Fifth, creating a temporary tunnel. And sixth is closing the tunnel. Thank you.
Now, moving to team 2, PGs from Jipmer Pondicherry. Do you have any questions to ask? Jipmer Pondicherry, Jacob and yes. PGs from Jipmer Pondicherry, team 2.
Hello, sir.
Yeah, you
Hello, sir.
asked your question.
So what you will do if there is any hematoma collection under the cartilage? Hello?
If there is a hematoma collection under the cartilage, then under the skin flap, then I will take a small nick and I will drain that hematoma, and we'll do the regular dressing.
And keep the suction drains for a longer time.
Okay.
More than 7 days.
Next, team 3, KGMC Lucknow. PGs from KGMC.
Hello. Do you know J scale criteria? What is it done for?
You mean just Dorfer?
Yeah. What for this criteria is for?
It is basically to decide if the patient needs
Atresia surgery
or not. So we'll have 8 criterias, and this will involve the condition of the ossicles, the joint between stapes, malleus incus, incus stapes, of stapes, and pneumatization of the mastoid, and a status of round window, oval window, and all of these have got 1 point, and the presence of stapes has got 2 points. If the patient gets more than 7 points, I think then we can go ahead with reconstruction surgery or tracheal surgery, and if not, then we should not go ahead.
Okay, yes. So there are total 9 points, and there are total 10 points out of 9 parameters.
Okay.
Okay, right. Thank you.
Thank you.
PGs from Stanley Medical College, Chennai.
From Stanley Medical College.
Proceed,
Hello,
Nisar.
can you
Ask
hear
the
me?
question.
Yeah. Suppose a patient with right-sided microtia comes to you, but the patient is sustained a trauma to that area and there is a severe scarring over the surrounding skin. So how will you proceed? What will be your plan for this reconstruction?
So I will reconstruct ear with the autologous rib graft along with the TP fascia coverage. If the surrounding scar tissue is not available for skin is not available for
Especially
coverage.
if the scar is over the place where our skin flap will be raised. If the scar is coming over that region, then we can harvest TP
So we can do
fascia.
single stage ear reconstruction with TP fascia, temporoparietal fascia.
Okay, thank you.
Team 5, AIMS New Delhi. PGs from AIMS New Delhi.
Yeah, am I audible, sir?
Yeah.
Good evening, everyone. Can you please describe the embryology, like the development of ear, from which branchial arches it develops and which one forms what part of the ear, and also the week, the gestational week?
So ear at the 5 week of gestation, from the first brachial arch three helix are formed, from which the tragus is root of the helix and the superhelix is formed. And from the second brachial arch, 4, 5, and 6 helix are formed, posterior helix, from which the antihelix, antitragus, and the lobule is formed.
Yeah, like it begins with the otic placode at 3 weeks of gestation. That is followed by ear or external auditory canal at 4 weeks, and then at 5 weeks, all of this. Okay, yeah, thank you.
Thank you.
Questions from Team 6, Bangalore Medical College. PGs from
Good evening, everyone. What is the location and dimensions of normal ear?
Normal ear is located 1 ear length posterior to the lateral or buttock margin, and the upper pole is located at the level of the eyebrow. The lower pole is located at the LR base, and the normal dimension length is around 55 to 65 mm, and the width is 50 to 55% of that length, that is around 35 to 40%, and it is 15 to 20 degree inclined to the vertical inclined posteriorly. And
Yeah, correct.
Thank you.
Next, PGs from CMC below, Team 7.
Who explained the single stage autologous reconstruction?
Sorry, you're not audible.
Gillies?
Who explained,
Autologous reconstruction is given by Tanzer.
who explained single stage autologous reconstruction in a single stage?
So your voice is not clear.
Question is, who explained single stage autologous reconstruction, ear reconstruction? Is it right, Bal Prashant?
Yeah. Hello.
Sorry, we don't know.
Okay. Fisher and Kasrai, who's like a students of Nagata, Fisher and Kasrai, who wrote the topic of microtia in New Nelligan, 5th edition.
Okay.
They explained a single stage.
From which place he belongs? Fisher?
Hello. Sir?
Which place he belongs?
CMC, Krishna Medical College, Velos.
Hello, Fisher? He's from Washington. He's from the Washington University.
He belonged to that.
Okay, sir. Now questions from Team 9, RML, New Delhi.
Yeah, good afternoon. My question is, if the child has bilateral microtia, how do you decide on taking the template, and where do you place the template or the new ear?
If patient has bilateral microtia, then we will make a template from the patient, from the individual of same age and height, and we'll put it a little. We will put it depending upon the syndrome. We will decide where to put it.
So usually if it's a female child, we take the template from the mother. If it happens to be a male child, we take the template from the father. And regarding the positioning, it can be done symmetrically on either sides. The calculations that we normally do, so that can be done, and it has to be whatever measurements we take, it has to be symmetrical.
Okay.
Thank you.
Now, any questions from Team 11, Kilpauk Medical College, Chennai? Team 11.
Good evening. Apart from the autologous ear reconstruction, what are the other methods known for recreating the ear pinna reconstruction?
Sir, you can use alloplastic material like porous polyethylene implant, and we can also you can use prosthesis for the reconstruction.
Any idea about any recent advances?
Bioengineered products wherein we'll put the bovine cartilage, bioengineered bovine cartilage in the framework.
Bovine cartilage will be allergic, right? So we can actually a patient's own ribs can be used. Yeah, you are correct. Yeah. Patient's own rib cartilage can be used, and it can be used in the scaffold. and can be engineered. So these are the upcoming. This is very recent, but the other two categories. Yeah, thank you.
Rohit,
1 minute, madam. Next, team 12, Mamsi, New Delhi.
Good evening, Mamsi Devi. My question is, for framework integration, Brent, Nagata, Fermi, what product they have used? What material they have used?
For
Framework integration.
You mean the
For
sutures?
framework suturing, huh?
Yeah.
for Nagat, Brand
Brent
used
uses nylon.
nylon 40,
Yeah.
and Nagata and Fermin they use 38
Stainless
gauge
steel, 38
stainless
gauge.
steel
Stainless
sutures.
steel.
Nagata used 38 gauge per 5
38
minutes.
gauge,
38 gauge.
stainless steel wire.
The Fermi used straight needles. Thank you.
Thread used.
Next questions from team 15, names Bhuneshwar.
They were double-ended thread.
Good evening. My question to you is, what is the percentage of microtia cases who can present with facial nerve palsy?
Ten to 15%.
Sorry?
10 to 15%.
Yeah, correct.
15%.
Thank you.
Correct.
Okay. Now, question from team 16, names Rishikesh.
Good evening. I have hello, am I audible?
You're audible.
Yes.
yeah,
Yes.
yeah.
So I've sent a picture in the chat box. I would like you to identify what it is and at what stage of Brent surgery, since you follow it, would you apply this?
Let me open it. The picture is not visible in the chat box.
Usually, we can't see any picture there. The chat
Okay,
box.
just a minute. I'll try sending it again to the group chat directly. Is it visible now? It's getting uploaded. Is it visible
Yeah,
now?
it's getting up.
No,
I'd
not
like you
yet.
to identify what this is, and since you practice Brent technique, I'd like to know at what stage would you use it?
This is a conformer. We use it after the evaluation of
Okay.
the ear framework.
That is stage
Stage 3.
3. Okay.
Now, PGs from Nizams. You have PGs from Nizams attending this session.
I think they are just finishing their exam probably.
Okay, ma'am.
It's okay.
Then we'll move to the next session, ma'am.
Yeah.
Ma'am.
Any questions from audience or other faculty, judges?
Yes.
Any
The
chat box questions?
single
Any
stage
faculty?
reconstruction. Hello.
Hello?
Hello, Lakshmi.
Sir, Venkatratnam, sir. Ask, sir.
Yeah. Single stage reconstruction was just touched upon as a passing mention. Can the presenters describe the procedure briefly? Am I clear?
Sorry, sir, we have not read about that.
Actually, they were not knowing that time also, no?
What is single stage reconstruction? How will you do it?
Actually, it's
We do it.
Balakrishnan from CMC, madam. He posed that
Any
question.
other batch?
Let the team who asked the question, they may have read, they can
using
explain.
TP fascia.
Let the presenting team answer the question. if
No, they
can.
said they didn't read.
No,
They
no,
don't know.
the team which asked the question.
TP fascia.
Temporal
they can
participation.
answer.
No, it's not the team. It is me who asked.
No, it
Dr.
was
B.
asked.
Venkatratnam, sir, asked the
Temporal
question,
participation.
how will you do the single stage reconstruction?
Actually, this question was
Students
asked by
can
some
do
team to the presenters. So if that team had read about it, they can reply here. No? I don't know which team was
CMC
asking
Vellore,
this
sir.
question. MC
Bal
Vellore?
Prashant asked that
Hello,
question.
hello, sir.
Yeah. Bal Prashant.
Hello.
Bala is here. He can explain.
Yes, sir. The single stage reconstruction was explained by the Fisher and Kasra. Actually, it's 2014. They've been in Washington. They have published a paper also, where they combined both the two stage of the Nagata into the single stage. Where the second stage of the Nagata usually this compromise the aesthetic reconstruction due to the soft tissue swelling, scar contraction, and there will be like skin graft contraction and all. So they combined the first and second stage into the single stage, where they use the projecting block in the first stage itself. So our pocket which we are creating should be more deep to accompany the projecting block also. So whereby like we can reserve the TPF flap for the further procedure if at all needed in the future.
Any other method in the single stage? That is okay. I shall tell in the interest of time. Single stage reconstruction is being done over the past 40 years. Any type of reconstruction of the framework you can do, either Nagata or whatever it is. Nagata is latest. But prepare the framework and make a V or T incision in the temporal region, then take the single stage, the temporoparietal fascia, hold it over that, and then suture it over drains. Simple. That's all. How will you identify the fascia? That is, the moment you open the skin, you will see the temporal artery pulsations. Then preserving them, go behind, elevate it, and then fold it back onto the framework. And then that's it. Put a skin graft on that and then cover it. That's a single stage. You can do with any type of framework. That's all.
So can I add something over here?
Please.
Yes, sir.
So as the students have rightly mentioned, one technique is you raise temporoparietal facial flap and cover the cartilage framework or midpore, whatever the technique you're using for the anterolateral and posteromedial surface, and cover it with the graft. That is single stage technique. But the disadvantage being the color match is not good. It is always dark in color, so it is not a preferred technique. What other people have tried, they have done 3D reconstruction like C-tire, one basal framework, one layer for helix and anti-helix, another for the a piece of cartilage posteriorly to elevate the cartilage in this single stage, so that elevation is not required because it's already elevated. But the problem is you need a lot of skin for this 3D reconstruction, and which is not available. It is extremely difficult to make a pocket which can actually hold this type of cartilage. And the third, which people have done, instead of giving incision anteriorly, they give incision at the level where you are going to make the helical margin. You give incision posteriorly, elevate the skin flap base anteriorly, raise the temporoparietal facial flap at the second stage, put the cartilage between the anteriorly raised flap and the temporoparietal facial flap, which will be covering the posteromedial surface. So that means the single stage, you are elevating, covering the cartilage posteriorly by the temporoparietal facial flap and the anterior surface with the anteriorly based skin flap. But the result is this technique has not been pleasing, and therefore this technique has not been used by many people. These are the only technique with which you can do single stage reconstruction. Thank you.
I want to ask few more questions. What is warping and the implications in reconstruction of the ear?
Ma'am, warping
You
is
have
a
described 3 techniques. Will you consider that now?
didn't get your question, ma'am.
What is warping? You are using postchondral graft, isn't it? What is warping? And while doing the carving, how you will overcome that?
Ma'am, warping is a tendency of the cartilage to bend around on particular
On opposite side of the
side of the
carved.
carved part. So
If we
if we suppose there are two sides of the cartilage, upper and lower,
if we cut the perichondrium of
the
on
upper
one side, then it
the
will
cartilage will
bend on
bend
opposite side.
towards the opposite
That's
side
So it
because
is
of
because
the
of the
compression forces.
internal forces acting, isn't it? Yes.
Internal compression forces, yes, ma'am.
May I
While
ask?
carving this,
And so
yes.
if we
May I ask a question, please?
Yes,
Sir,
sir.
the answer,
While
is it acceptable to the panelists? And I wanted their comments. Is it now applicable for while carving this cartilage? What precautions to be taken?
Ma'am, before we answer your question, can I ask sir to ask question? Dr. Bhattacharya wants to ask a question.
I just wanted to ask that suppose while harvesting the cartilage, you damage the pleura. What do you do?
If we damage the pleura, then we'll put a suction catheter to that rent, and we'll close the wound in the layers, and then put a suction to the catheter, and with the positive pressure,
we'll ask the anesthetist to give positive
pressure,
pressure,
we will remove the suction tube.
remove it as quickly as possible while the anesthetist is giving positive pressure
And
so
we
as to
close the
occlude the rent.
Will you, before that, would you like to assess the?
How will you assess there is a pleural
Yes,
tear?
sir.
First, you tell that.
We'll raise both the sides of the
and we put water in that
Saline.
normal saline in the
cavity.
pocket, and give pulse. Sorry.
We'll ask the anesthetist and
Give
will they
positive
give
pressure. Then we will see for the air bubbles. If they're there, then
If it is very small, then also you'll put a drain, or you'll try to do something. Or if it is large, of course, the drain.
if it's we'll close it.
We have
yes.
If
Any
it
other
is
method?
small, what will you do? If it is a large one, what will you do?
If it is a small rent, we'll do as you described. We'll try to close a pleura and put a small drain through it. And then while closing it, we'll ask the anesthetist to give positive pressure. At the last stitch, when we reach, we'll quickly remove the drain and close it while the anesthetist is giving positive pressure so that the lung inflates. But if it is and then we'll check if there is any air leak. So if there is still persistent air leak, then we probably have to, and if it is a larger end, then we probably have to go with chest tube insertion, chest drain
ICD insertion.
Okay.
Anything else you want to ask, sir?
That's it.
Lakshmi,
Sir.
This is in continuation of Padam Singh sir told. That is, it's not to antagonize, it is to add the point. The point is, when the single stage reconstruction covered by temporoparietal flap and a skin graft, the color change or color difference is definite. It will be different. But the management is, in the females, they will manage by hairstyling. So they want something, not to reveal empty place. They want something, and they will manage wisely by hairstyling. Number 2 is by cosmetics, by the makeup. These are the answers. Thank you.
Sir, to
Sir,
add,
Bandari, sir.
Sir, to add,
Bandari, sir.
Dr. Bhatt, if you take the graft from the scalp, the color match is definitely very good. So if you're putting the graft, especially for the anterolateral surface, put the graft taken from the scalp, the color match and texture is definitely good. So I agree with the Dr. Bhatt, what he is saying, absolutely right. So ma'am, you asked something about the warping.
Yes, sir. Warping and balanced carving. These are the two concepts.
The students are supposed to answer the question.
If not,
Balance
they
carving is when we
want description by the panelists, sir, with your experience.
balanced carving is when we take small cuts into the cartilage so that the forces are balanced, as in we take small V-shaped cuts into the cartilage at appropriate distance so that it balances it does not curve towards.
So I would like Dr. Uday to answer the question, because Master is written an article which is excellent article in Indian Journal of Plastic Surgery. Dr. Uday, but please.
Yes, sir. The students are right. What they said that the cartilage bends. So the response of the cartilage to the surgeon's knife is not capricious. There is a method in it. The more you carve, the more it is going to bend, and thicker the cartilage, lesser is the warping. So when we are carving a cartilage block, a big block, just like, for ear reconstruction, because of the inherent thickness of this cartilage, there is a very, very little chance that this will warp. So the question of warping would arise only when we are carving the cartilage for rhinoplasty or any other thing. But for ear cartilage, I don't think it would really matter. It would matter only in the helical pieces, or maybe in the piece that we are using for the tragus, for the antitragus, So small
Yes.
pieces, it may warp, but the basic base plate is not going to warp. So our foundation is to be really good, but in carving the helical rims, we must follow the principle of balanced carving. That means we must, because it is a curved thing, so if we have a straight piece of cartilage, we must make it curved by incisions on the convex side, and this has to be really in precision. Okay, so the space, the depth, spacing and the depth of the incisions that we are going to make to create a curvature, that really matters. And if we are doing that, it has to be braced by another thinner plate of cartilage. So whatever curvature we achieve, that is braced. There is another thing that would prevent further recurrence. So that is the way you can counter it.
So
And
we
the
can
article
use.
the article is there for them to read. It is called the precision carving technique, published in I think 2014. And a follow-up article is published in the recent journal, has the follow-up article of that, long-term follow-up. So we have two articles based on that technique. It is called Nair Hospital Precision Carving Technique, NHPC.
Yes, sir.
So the
I want to highlight that point.
So the recent issue
they
has
should
this,
know.
Yeah.
So while carving the helical rim and anti-helix, these principles can be used. So one more question to the students. What is the treasure cleft will be associated with the microtia? Which number? Commonly associated.
Treasure cleft number 7.
Microstomia.
Yes. If there is a...
I have a question, ma'am. Can I ask? Yeah.
Yes, sir.
So I have a patient where the patient attendant don't agree for a young girl for going for a costochondral graft. What can be the other options available?
Other options available, you can give option of Medpore implant to the patient.
Medpore is not available in India now.
Or we can give the option of prosthesis if they are not agreeing for autologous reconstruction.
Prosthesis we can also integrated prosthesis we can ask.
Okay.
Nothing like prosthesis. It's the best.
Okay.
In such situation.
Sorry, sir.
In such situation,
Okay.
prosthesis is the best. What you said is correct.
Okay. Thank you.
And if there is external auditory matters, atresia also associated with, which one you will advise to get it done? Ear reconstruction or...
Which one first?
First, what will you advise?
Ma'am, we are facing network issues, ma'am. We didn't listen to your question.
Hello?
Hello,
If
yes,
there is
ma'am.
a atresia for the external auditory canal, how will you go ahead? Which one is first, ear or external auditory canal?
we will do ear reconstruction, and ma'am, we will do ear reconstruction, and then during the second stage, we ask for the otologist to do the canaloplasty when we elevate the ear framework, and we'll ask them to do that procedure.
What is the reason?
Because if we do otoplasty first, there will be scarring in the
Scarring in
area
the-
of the skin envelope, and it won't be accepted.
Yes. If there is it is a congenital anomaly. If there is a low set ear remnant, what will you do?
So we will do reconstruction at the normal position only, because they are mostly anterior and inferiorly placed. So we have to go a little posteriorly and superiorly.
And we have to manage the hair.
So you will exercise that lower one.
Yes, ma'am.
We did not hear you, ma'am.
So if the lobule is situated at lower down position, will you use it or you will discard it?
If it is
I request the panelists to answer this.
Compared to the opposite side, ma'am,
if it is too low,
then
we have to
we have to probably discard and recreate the
Recreate the
lobule with the other
along with
methods
the-
as described.
along with the in that cartilage frame only we have to create
Cartilage frame only we carve the lobule also, and then
What you will do?
Even I do that the same thing, sir.
if it is very asymmetric, then we remove.
In this case, there is a remnant cartilage. Will you discard the whole thing or will you use the remnant cartilage for anything else? In your case.
unnecessarily occupy the
In our case.
yeah in our space, and it will be unnecessarily occupy the space in the pocket, so it will be difficult to put the ear framework inside, and it is
Will you totally remove it or you will use it for anchoring your cartilage framework?
no, ma'am, we will remove it. It is elastic cartilage.
What is
Or
the
it is
opinion
better-
of the other panelists? Will they
Or it is
remove the
better,
totally
otherwise
discard
better to
the
keep it for
whole
some time.
cartilage?
Yes.
Huh?
Or should we preserve it till our work is done so that it can be used for some other purpose? Cartilage is there, it may be used. So in the first instance, we should remove it, discard it, or we should wait. Madam asks the
Sorry.
same.
So will you please repeat your question, sir?
Will you discard the whole thing or partly you will retain or will you use this remnant cartilage for anything else?
At a later date even.
We can use it at a time of ear elevation if we bang that remnant cartilage.
Pardon?
Tragus, we can use that for tragus creation or for ear elevation if it is the larger one.
Ma'am, can I add
request
something
the
over here?
panelists to answer.
Yes.
Ma'am. So if the lobule is too lowly placed, most of the time lobule which is very lowly placed is almost atrophic, very small lobule which can be taken out. But as he's rightly said that it should not be excised in the first stage, because sometime if the lobule is little larger or well formed, can be used in case there is exposure of the cartilage in the lower portion. So that lobule probably can be used for coverage of the exposure of the cartilage. If the lobule is very lowly placed and small, it can be taken out. If it is well formed or very lowly placed, don't excise in the first stage. Keep it for our rainy days, maybe required for the exposure of the cartilage, or maybe in the second stage can be used. Now, if the cartilage is low but not very low, it can be moved up. That is one. Sometimes what is very difficult when you have a well-formed external aortic meatus, which is very lowly placed, you don't feel like excising that, then that well-formed external aortic meatus can be moved up by giving incision all around based on the vessels, perioral vessels, and it can be mobilized at least 1.5 to 2 centimeter based on those vessels. It is a tedious dissection, but I've done in 2 cases, and it can be moved up. So it is a well-formed external meatus. You don't feel like excising that. You want to move it up and can be used for the reconstruction of the ear, unless it is very small, which can be taken out. So lobule, if it is small, very lowly placed, can be taken out. If it is a well-formed lobule, don't excise that, it can be used. External meatus, well-formed, should not be excised. It should be moved up based on the vessels around the abnormal ear, external meatus.
Sir, ear cartilage remnant, will you use it or discard it, sir, totally?
Remnant cartilage we make into pieces and put it back in the chest.
Okay. Not for any component
No,
of the
used
ear.
for the ear reconstruction, but sometimes you get quite of the cartilage. I will pack it in the pericondylar pocket, and it can get consolidated for reconstruction for the cartilage, costal cartilage. We never throw it away.
Sir, you have done lot of reconstructions for burnt ears. So what is the it will be associated with the skin scarring around?
Yeah, before that, the question once you asked, how would you come to know the right thickness of the skin when you're making the pocket? And one of the students rightly said you should be able to see through the light through the skin.
Yes.
The question is the skin. See, if the skin is very thin, then also you'll be able to see the light through the skin. If it is thick, then you'll not be able to see it. So my advice would be, when you're raising the skin from the vestigial cartilage, that is the plane you continue. And that plane will have skin and a thin layer of separate tissue. If you are going little into the scalp, the plane would be just below the hair follicle, which is superficial of the temporoparietal facial flap. And if you continue that layer, that will be the right thickness. And this thickness will have skin and a very thin layer of separate tissue, which is very difficult to actually tell how much that will be the thickness. But there has to be some separate tissue in the skin, otherwise it's not going to survive. Because if you raise only skin, then also you'll be able to see the light through skin. So you should be able to raise the skin with a thin layer of separate tissue so that it survives. And as of now, according to Nagata, you want to see a perforator in the auricular region. So I always feel for the perforator with the Doppler, and we save that perforator, raise the skin, and slide the cartilage around that perforator. That helps maintaining the vascularity of the skin pocket. That is extremely important as of today. So you want to feel for the perforator in the auricular region. That is extremely important. In the case of temporoparietal facial flap, as I've told so many times, the artery lies within the fascia. The vein is on the superficial aspect of the fascia. I will always give adaline saline before reaching the fascia. Wait for 20 minutes by watch. And when you are injecting, you have to be in the right plane. You start from the top of the vortex. Once you make a bleb, then you go through the bleb and gradually fill the area. When you are injecting, you have to be in the right plane. So once you give the incision, you elevate the skin with a thin layer of subcutaneous tissue. The hair follicles should not get exposed, otherwise you will have alopecia. So injection of adaline saline is extremely important. People usually are worried about giving injection of adaline saline in the plane. But I tell you, without that, it's extremely difficult to raise the fascia. So I always give adaline saline in the plane, wait for 20 minutes, raise the skin with the subcutaneous tissue without exposing the hair follicles. You'll be able to see the superficial vein on the superficial aspect. And that is the time when you have to be very careful, because the minute tributaries which are draining into the superficial vein, the vertical length is very small. And if you don't cauterize before cutting it, it makes a rent, a small rent in the superficial temporal parietal, superficial temporal vein. which is extremely difficult to stop with the cauterization, because then you're cauterizing the wall of the vein. And if you cauterize the wall of the vein, you will have distal necrosis exposing the cartilage. You have to be very careful when you're raising it, because you can hurt, you can injure the vein. Artery is within the fascia. It is quite safe most of the time. And usually 14 into 14 centimeter flap is required for covering the total anteromedial and posterior surface of the cartilage. Right, man?
Can I just
We'll move to
Sir.
Sir?
I just wanted to make a comment. During one of the lecture of Dr. Bhandari, I was very obediently listening to him.
Sir.
And he said in that lecture that one of the important step is to create the pocket in proper
Yes.
plane. And he, so much so, he mentioned that this stage, I don't leave it to my residents.
Yes.
He does it himself, because that is so important. Otherwise, all complications may happen.
Cartilage is
So
taken
I
by my
remember. I remember.
cartilage is taken by my residents, but pocket is done by me.
Yes, I remember that.
Sir, I would make a comment. It is a bad thing. How will the residents learn?
In the final year, in the last 2 or 3 months, he is allowed to do that.
Yeah, okay. Yeah.
That's
That is
his
fine.
criteria.
That is fine, sir. Yeah.
Shall we move to the next session, sir? So, Rohit.
Yes, ma'am.
PGs?
Can you see the spotter?
Yes.
10 minutes time is there, so you have to quickly tell the diagnosis and treatment.
This is the shows the X-ray of probably the left hand, showing complex syndactyly, complicated syndactyly of the left hand involving the second web space. It also shows bifid third metacarpal and it's an absence of less number of one metacarpal and bifid third metacarpal. Along with that, there is also absence of one digit.
One ray.
One ray.
Ulnar. Or middle. Central.
Because you said complicated, complex. So any difference between complicated and complex syndactyly?
In complicated syndactyly, there is sharing of structures like a tendon, neurovascular bundle, or there may be an extra phalanx in between the fingers.
And in complex?
In complex is associated with both the soft tissue plus bony fusion.
And what is oligosyndactyly?
Oligosyndactyly.
And what is brachysyndactyly? These are the common terms which will be asked in the examination.
Brachysyndactyly is associated with the it is syndactylization of the short digits, and in oligosyndactyly there is a number of digits are also less.
Brachysyndactyly.
So brachysyndactyly, small digits with synthesization. Oligosyndactyly means there are lots of digits also. So what is the principle of releasing this syndactyly?
Principles of
first important principle is the web space should be created with the
so I would advise you one at a time, either of the two, so that we can hear it clearly. One at a time. Whosoever wants to tell. What are the principles of releasing of syndactyly?
Principles of syndactyly release involves creation of an adequate space, preferably with the use of flap. And then the rest of the raw areas are lined using split thickness graft, and the joints are also to be covered with the flaps.
Fingers. Zigzag incision should be taken for separation of the fingers. Syndactyl should be released completely. One side of the rigid should be released at a time. Waist space should be reconstructed with the flap only, and the triangular finger flap should cover the PIPJ joint.
So when you said the spaces should be covered with the flaps, joints should be covered. And what about the release? It should be straight release?
No,
it should
sir.
be zigzag
Zigzag.
release, described by Kwame.
And not in this patient. If you have 3 fingers joined together, why not release all the fingers simultaneously?
There won't be any problem with the side digits, but the central digit will have venous compromise, because the venous drainage of the finger is mostly by dorsal venous system, and if you elevate the dorsal rectangular flap from both the sides, then we will compromise the venous drainage of the middle finger, so it can swell later on. It will have swelling post-op.
To best clarity, you're talking about the artery or the vein?
Vein, I'm talking about vein.
So venous drainage would be hampered, therefore you release only one at a time.
Yes, sir.
And if there is a sharing of the tendons, what would you do?
Then the finger which is having the insertion of that tendon, we will take the tendon on that side.
No, it will depend upon if there is sharing of the flexors or extensors and how much which is dominant. It will depend upon so many factors.
Yes.
If the bones are fused distally, how are you going to cover when you release the fingers, the bones will get exposed. So how are you going to cover that portion, because you don't have enough skin over there?
We will put a split thickness skin graft. As the exposed area is a cancerous bone, the graft will take up.
Can you come
or
because your bone would be exposed?
If bones are exposed, we can either do Bug-Granco flap to cover that area near the paranacle region. If it is not available, then we can directly put a graft over the cut bone. Because it is cancellous, it will take the graft and it will heal.
How old is this child? Maybe around 2 years?
Yes, sir.
So what is the right age to release this syndactyl?
For when there is a length discrepancy, like a thumb and index finger and ring finger and the little finger, it has to be released as early as possible. Once the patient is fit for
come to this patient, 2 fingers are joined together. What will be the right age for this patient?
We can release it up to after 2 years also, because this is a index finger and a ring finger which are of the same length.
Why after 2 years? Why not after 5 years? Or why not before 2 years? Why that cutoff line is 2 years? Or should it be before 2 years? Something to do with the pyramidal tracts?
Something to do with? Something to do with?
Pyramidal tracts which are developing in the brain. Cortical representation.
Cortical representation.
So that pinch.
The pincer, the grasp, and the ability to feel the hand in space usually develops after 1 year of age. Starting from 1 year of age, the grasp and the ability to recognize the hand and the fingers in space separately, and the comprehension, it develops after 1 year.
I'll ask in a different way. If you have to do a pollicization of index finger in a patient who is pars flatant or absent of thumb, what should be the age for pollicization of the index finger?
Sir, 1 year of age.
So
after
polysation has to be 1 year of age and syndactyly has to be after 2 years. Why do you want to do it before 2 years of age in polysization?
Sir, because otherwise the child will start neglecting the even if we do polysization after 1 year of age, when the child has already developed that cortical representation, then he will start neglecting the polycized finger. He won't be using it.
Because pyramidal tracts are developed in the brain, there is a cortical representation of the index finger. If you do it before 2 years, it will be taken as a thumb by the child. The same thing happens. So all congenital anomalies preferably should be done before 2 years of age. Because once you release it, it will be taken as separate fingers. Not a problem in syndactyly, but especially in polysization of the index finger. That's all, ma'am.
Any other question? Any panelists?
Yes, madam, I have a question.
Yeah, please ask.
If
Ask,
you
sir.
have syndactyly of all 5 fingers, all 5 rays are stuck, in how many stages would you release? How many operations will be required? All 5 fingers.
Including thumb?
Including thumb, yes.
3 surgeries will be required. First, to release the first web space and the fourth web space. In second stage, we will remove. We will release the first, second, or fourth, third web space, and then last one remaining will release later on.
Three stages.
So we can even leave the 2 fingers combined because
No. You want to release all the fingers. So how many stages will be required?
So we can do it in 2 stages also. First, we'll release the first web space and the third web space, then second and fourth web space.
All right.
Looking at the X-ray, what do you think it is? The metacarpals. Can you listen to me?
Yes, ma'am.
Yes, ma'am.
About the metacarpals, do you want to do anything or?
When the metacarpals look short, and they are also fused. So
there is synastosis between the 4th and 5th rays, which is incomplete. So there is abducted little finger, probably that may come in the way when the child keeps, male child especially, keeps the finger in the pocket or in something. So that may need a realignment of the finger, but it may not be at this stage. So how long do you need to follow a syndactyly child? Once you have operated, how long do you follow the child? For what reasons?
At least up to 1 year to look for the flexion contracture or deviation of the fingers.
In other words, what complications do you expect and how long do you want to follow and any further corrections?
We are expecting a web creep if there is a contracture of the graft which we apply on the lateral aspect of the web space, or there can be a flexion contracture because of the graft that we place on the adjacent side of the fingers. These 2 complications, ma'am. Or there can be a deviation also of the fingers.
Yeah. Angulations and rotations, web creep, all these things we have to keep following, and any complication probably you need to intervene. That is the idea. Till the skeletal maturity happens, probably they may have these complications.
Madam, can we move to the next thing?
Yeah.
Next question.
This image shows 3D CT reconstruction of the skull, and the axial section shows a cystic lesion in the unilocular cystic lesion in the mandible, and the angle of the mandible just behind the second premolar, and the coronal coronal just behind the second molar, and the coronal section shows presence of tooth in the cystic cavity. So suggesting this could likely be a dentigerous cyst.
Where do you see the tooth in dentigerous cyst?
In the city, plain city, NCCT on the right side, the lower one, right side. Right lower corner, ma'am.
I could not get you.
This one, ma'am.
Wait, you mean to say this? My
No,
arrow
no,
is not this.
right to this one.
Okay, that is the one you are telling the tooth is there in the cyst. I mean, whatever lytic area. So
Here
you
also you can see the root of the tooth inside the cyst.
you consider this as dentigerous cyst. Is that the location where you see the tooth in dentigerous cyst?
We
How do
usually
you see in dentigerous cyst?
we usually see it at the base, ma'am. The base of the cyst, the lower part, unerupted tooth, basically.
What is the relation of the tooth to the cyst in general in dentigerous cyst?
Because it arises from the epithelium between the enamel and the root, ma'am.
So where do you expect the cyst to be and tooth to be?
It will be in the lower part of the cyst.
Yeah.
Lower part of the cyst.
Then you want to change your diagnosis or consider something else? The differential diagnosis for
the other type of cyst which could be present in the posterior part of the mandible is keratogenic, odontogenic OKC. Keratogenic cyst.
Okay, that is one possibility.
Because it is unilocular. Other than that, other cystic lesions are unilocular cystic lesions are radicular cyst, which are again associated with infection in the tooth root. So they should be having a tooth above them, and and under the root of which there will be a cystic lesion.
Yeah.
And apart from that, other cystic lesion could be ameloblastoma most of the times, but they are multilocular, and they will have so bubble appearance.
Okay. What could be the size of the cyst in this case? You have not mentioned.
Yes, ma'am. It could be 3 x 3 centimeters.
Okay.
Yes, ma'am. Like 5 x 3. So
5 × 3 into
5 x 3 into 3.
Okay, fine. How do you want to proceed with this patient?
Ma'am, I would like to can confirm my diagnosis by doing an aspiration cytology of the cystic lesion, and after confirming my diagnosis, I'll
What do you expect in aspiration cytology?
Ma'am, if it is a dentigerous cyst, there could be a simple serous fluid, whereas in OKC, there will be a cheesy material, like it won't be serous. And then in ameloblastoma, usually we won't get anything because most of the times it can be a dry tap.
Needle aspiration is not an ideal investigation for bony swellings. It is probably better to go for incisional biopsy. You have to confirm the diagnosis. Yeah. So you have to confirm the histopathological diagnosis, and then you can proceed with the treatment. So what do you plan for this particular swelling?
Ma'am, because it is involving the outer cortex also, I'll go ahead with the surgery, and I will we prefer the patient to have either nasal intubation or North Pole intubation or North Pole tubing, and then we will take an incision. We can go ahead with extraoral approach also, since it is present in the near the angle, because the intraoral approach will be a little difficult. And then using the extraoral approach, I will go and then because this seems to be a larger cyst here, I will go ahead with removal of the lining of the cyst and marsupialization. And I will the lining of the cyst, I will subject it to histopathological analysis.
You're talking about the incisional biopsy part or final treatment part?
We can do marsupialization, and then
what is the size you told?
Ma'am, 5x3x4.
There is already lytic area in the outer cortex.
Yes, ma'am.
If it is ameloblastoma, what do you do?
Ma'am, because the bone is already weakened in that area, then we remove that part of the mandible and then reconstruct it with osteocutaneous flap cover.
This is size wise, this is a tricky size of the cyst, and the location is also tricky. According to the size, if it is 3 to 4 centimeters or something, probably you can do a different approach in a different way. If it is larger, you approach it in a different way. So if it is a smaller swelling, how do you approach, even if it is ameloblastoma? Or if it is a larger swelling, how do you approach?
If in case it is an ameloblastoma, then and if it is not involving both the cortexes, we can just enucleate that part of the swelling, and because the outer cortex is intact, we might not need a formal bony reconstruction. But in case of a larger cyst, and if it is also involving both of the cortex and both of the cortex need to be removed, then we'll have to do a bony reconstruction.
What are the different methods of treating ameloblastoma, you know?
Last 1 minute.
We can go ahead with curettage, enucleation, and excision.
Curettage and
enucleation and ma'am, excision or excision.
You do only curettage and leave it, or do you want to do any other things? How do you stabilize that bone? It is already lytic area.
Can you see the
And we can
thin
put bone
cortex
graft.
inside? Can you do something for the bone?
We can put cancellous.
Yeah, curettage and cancellous bone for
Bone
the
graft.
smaller lesions.
Yes, ma'am.
If it is a larger lesion, as you said, probably you can consider bone reconstruction.
What do you mean by enucleation?
Enucleation means we remove the entire lining of the cystic cavity, and we leave the cavity as such, and sometime at a later date, the cavity will reduce in size because of the bony growth from the surrounding tissue. Basically, it is the removal of all the lining of the cystic cavity.
You can tell that instead of using enucleation word.
Yes, sir.
Can we move to the next topic?
Yeah.
These are the liposuction cannulas with the suction machine.
And these liposuction cannulas will have different sizes as mentioned on the handle, and they can also be differentiated based on the opening of the liposuction cannulas. They can either be a bucket handle type or a Mercedes-Benz type, and then the different sizes will size of the cannulas can be of different sizes based on how much volume of the fat do we want to aspirate. And usually we use a size 4 or size 5 liposuction cannulas for gynecomastias. And then this is the suction machine which we use in standard suction assisted liposuction.
For a liposuction cannula, what are the different components you consider when you are planning to do a liposuction?
First, with the size of the cannula, ma'am.
What size? Size means what?
The diameter of the opening. Oh,
okay, sorry.
The diameter of the cannula.
Opening.
Diameter of the cannula.
Diameter of the cannula. Then
the length of the cannula, depending on where we want to reach, and the type of opening of the cannula.
Okay, fine. So you can use different cannulas in different locations. Can you tell the minimum size and maximum size, and where you'll use different sizes in different according to the regions?
No.
For abdomen, we will require longer cannulas with the larger diameter.
Larger diameters.
And
fat pockets are also thicker. And then for liposuction in gynecomastia, we usually use a 4 or 5 size cannula. And for fat grafting, if we want to do liposuction, then we use a 3 mm or 2.5 mm sized cannulas.
What is used for larger diameter? What is the shorter diameter, smaller diameter used for?
Larger for abdominal and back liposuction.
Larger is for deeper fat and smaller is for superficial fat, the contouring part. What is the last one which is in blue color, that instrument? Yes.
You can see the tip of the cannula here.
Observe the tip.
That is to cut through the fibrous tissue.
What is it called? Subcision needle.
What does it do?
Subcision.
It starts with P.
Is it subcision needle?
Trocar.
I'm assuming it is subcision needle.
Toledo tip.
Exactly. It's Toledo's.
Toledo tip.
Toledo.
Toledo.
And what should be the pressure of the suction machine when you're doing liposuction?
Around 700 mm of Hg.
Sorry?
Around 700 mm of Hg.
So if inside the suction machine is also 700 mm and outside is 760, how will it suck? Atmospheric pressure is 760?
760, sir.
And suction machine pressure is also 700. The difference is only 60. How will it suck?
Because we are not equalizing it with the atmosphere. It is a closed suction. As in nowhere.
Unless you have a difference between the pressure inside the suction machine and outside, that is atmospheric pressure, how it is going to suck? The pressure inside the jar would be around how much? It should be 30 torr, it should be 100 millimeter mercury or 700. You understand by torr? If inside the pressure is 30 millimeter of mercury, the difference will be 730. Then it will suck. If inside is 700 millimeter, the difference is only 60 millimeter. How it is going to suck? What I was asking, the pressure inside the suction machine, inside the jar. Anyway, you tell me the difference between laser and laser liposuction. What is the basic difference between laser and laser liposuction?
A laser liposuction will use sound, as in will use ultrasound energy.
Both are used for liposuction. We're asking the basic principle between laser liposuction and laser liposuction, and add to it the power assisted liposuction.
So, laser will use sound energy.
In laser, the photon energy used for liquefaction of the fat, and in laser, sound
It is the
energy
sound energy
is used for liquefaction.
to break the fat globules.
Dr. Parag there, he does a lot of aesthetic surgery. Dr. Parag would like to ask some questions. Dr. Parag?
I was going to ask the same question, sir. What is the difference between... you already asked the same question.
So please explain the students. They will understand now.
So in laser-assisted liposuction, there is a beam which conducts the laser energy to the area which you want to emulsify. And this is also going to heat up the tissues a little bit. So this causes something called as coagulation. And then the fat globules which become liquefied can be aspirated after the laser has been used to treat the fat. While in ultrasound-assisted liposuction, you will first use different size cannulae depending upon whether it is for gynecomastia, whether it is for tough areas or secondary liposuction. You can choose various types or sizes of cannulae to deliver ultrasonic energy. Now, ultrasound travels faster in water as compared to air, and therefore infiltration is very important when you are performing ultrasound-assisted liposuction. So you need to really tumus the tissues well, and then you move the ultrasound probe back and forth, the cannula, which causes disruption of the fat globules and emulsification, and then these can be aspirated using hollow cannulae. So though it is an additional step of, first liquefying the fat and then aspirating as compared to the traditional or the suction assisted liposuction, it has been found that the fat removal can be much more complete when you use either ultrasound assisted or laser assisted modalities.
To add something, what is the difference between, to the students, difference between regular suction assisted liposuction and a power assisted, that is laser liposuction? Technical terms, two terms, one term each. If you can't tell, I will tell you to save time.
In suction assisted, we have to use mechanical energy
Force to break down
the fat.
Whereas in laser, it is
power assisted. The
laser, it is the ultrasonic energy which is being used to
emulsify the fat.
Remember the technical terms. Hello. Remember the technical terms. In the suction assisted liposuction, it is tunneling. In the laser and other ultrasound assisted liposuctions, that is cavitation. You please read up the difference between these two later. Over. My part is over. Take over, please. Others.
So we have 1 more minute for discussion. Or if you want me to move to the next part, I will move.
Any questions? Any more questions?
Okay. Since time is there, I will ask one question. How will you decide on the table how much fluid we have infiltrated, whether you have infiltrated enough or not? How do you know?
Okay.
We have to make that area tense enough.
That better term is turgidity.
Turgidity.
And also color difference.
Yes.
Okay, go ahead.
And fountain sign.
Yes.
The fluid will come out like a tap. Fountain.
Yes, but we are not supposed to let the fluid out. It will not work.
It's a
Go to next.
It's a right leg showing a wound over the lower 1/3 of the leg with a exposed bone and pale granulation tissue with a multiplanar external fixator.
In situ.
In situ. And a small wound around 3 to 4 centimeters over the dorsum of the foot at the base of the fourth and the third and fourth toes.
You have not described the extent of the wound.
It
Just told the lower third. What is the extent?
It extends 10 to 12 centimeter above the medial malleolus up to the till the 2 to 3 centimeter above the lateral medial malleolus, and horizontally it extends from the mid-lateral line of the leg medially and laterally till the tendon Achilles region. Posteriorly.
Did you
And
say
the
lateral extent?
Yes,
laterally till the
goes
midline
down
of the posterior part.
in this photo, it is visible going down.
Where do you see the lateral extent?
Lateral extent till the posterior midline.
In this photo, it is.
In the photo, I'm asking.
So in the photo, the entire lateral aspect is also involved. In the lower third of the leg.
Okay.
And the X-ray is showing well-aligned fracture with the external fixator in situ.
2 kb.
And 3
kbs. 3 kb.
3 kbs
spanning the ankle joint. And so our plan of management for this patient would be.
First, I would like to send.
Examine the patient.
We'll examine the patient to look for the peripheral pulses and
sensation
also
and
about
movement.
the sensation and movement of the toes. Then I would send the wound culture sensitivity and we'll start antibiotic according to that. And once the then I will plan for a reconstruction, flap coverage of the defect, mostly with the free flap.
We'd like to take free ALT.
Free anterolateral flap. Flap.
So are you planning to reconstruct completely by yourself, or is there something else involved in it?
We have to involve the
orthopedician for development of the
first thing you have to do is orthopedic consultation. Why?
First, also to check if the bone has united well and the status of healing of the bone, and whether the bone needs.
Is the fracture exposed?
Yeah, fracture is exposed.
Yes, there is a part of the bone exposed on the end.
You can see some dots.
Yeah,
yes, they have tried drilling the bone.
Okay. Can you see the joint also exposed? Slightly. Okay. What do you want from orthopedician?
We want complete debridement of the dead bone if it is there, and also if they want to realign the external fixator according to that, or want to do
We
something.
would also want them to remove the rods of the external fixator while we insert the flap. And if
That
they
is the
want
first answer. That is the first answer.
yes, sir.
Yeah.
We would want them to remove.
What do you think about the bone? What that is exposed? What is the extent exposed, and what is the viability of the bone?
The lower part of the bone is yellow in color. Is it lusterless?
5
mostly
centimeters lusterless.
dead, and depending upon that setting, it could be infected.
Infected
So
as
it
well.
has to be removed. And the upper part of the bone shows granulation through that drill holes.
Above the
So-
drill holes, we can see that part of the bone covered with granulation tissue.
So we can keep that bone.
So you think that it is viable and you can keep the bone?
No, ma'am. The exposed part of
cortex
the
will be,
bone has to be
chiseled.
out. It has to be removed, and we have to see. We have to chisel the bone out till we see healthy bleeding points from the bone.
What do you
There is a name for that bleeding points. Seeing the bleeding
Paprika.
points. What is
Paprika sign.
exactly?
Paprika sign.
So what do you expect once the bone is chiseled, and you may, do you want to know the duration of the wound?
What, ma'am?
Is it important? The duration of the wound?
Yes, ma'am.
Looking at
the bone
granulation, it must be a chronic wound.
Yeah.
This one.
The longer the bone is exposed, there are high chances that it is dead and necrotic. So it has to be removed before flap cover, otherwise it will form persistent sinus under the flap.
Draining sinus and may compromise the flap, may cause wound adhesions also around the flap.
So you have to anticipate what are the possible things from orthopedic point of view. One is probably that anterior cortex may go. The other thing is joint may get exposed. So it may be infected joint. So orthopedician may plan for proper arthrodesis of the joint.
Yes, ma'am. If the joint is
All those things you have to consider in your planning, and accordingly you have to plan with the orthopedician.
Yes, ma'am.
So then comes the question of cover. So if it is, so now tell me whether it is fasciocutaneous or muscle flap.
So I would like to do a fasciocutaneous flap.
Can you cover whole of the wound?
Using ALT.
Which pedicle you want to take?
Posterior tibial artery.
Posterior tibial artery.
Posterior tibial artery. So with the posterior tibial artery, can you go all around the ankle with the ALT?
Yes, we can cover the entire with the ALT.
And
it may or may not possible, but you should be prepared for muscle also. And it also depends on your future plans. If it is going to be a arthrodesis, you may not need to open it. If
yes,
in
that
that
case we can
take
put a
muscle
muscle flap.
to fill the
Fill the cavity.
Yeah. Any questions, other faculty, please?
So would you like to confirm the continuity of antitibial and posterior artery?
Yes, sir. Before that, we have to that I already have mentioned that we have
in
to see for the
examination, we have
peripheral pulses also.
You're able to feel the artery?
But in this patient, there is a lot of edema, sir.
So there is a lot of
lot of
edema, so
edema
we'll have
around the
to
ankle.
go for a color Doppler of the.
So when you are taking posterior
there are
artery,
chances that the ATA must be damaged.
so the anesmosy would be end to side or end to end anesmosy with the posterior?
To end to side.
End to side.
In case if it is
End to side. And
Yes,
where do you expect the anesmosis to be done? Because there is a lot of injured area.
it should be away from the trauma zone, somewhere in the middle of the, just at the lower part of the middle 1/3 of the leg.
Do you think that any local flap can be done to cover the area which is exposed bone? Rest of the portion probably can be grafted.
Yeah, rest of the Lateral part can be grafted, but for
Lateral
the
part
medial
of
part,
swell granulation
Can be
will
grafted.
take the graft. So is it
but
possible to do a local fasciocutaneous flap to cover the exposed portion of the bone?
one of the options is a reverse flap, but the pedicle part of the reverse is also
One of the option is, you told me one of the option is?
It would have been, but there is a granulation
It
over
would
the.
have been. What are the possibilities? Is there any possibility of any fasciocutaneous flap, pedicled or perforator based?
Sir, if
We can try perforator
it
based
is
flap
from the
based on the
posterior
posterior
tibial
tibial
artery.
Please speak one by one.
Perforator
Is
based
there any
propeller.
possibility of perforator based flap over here or no?
Yes, the perforator based propeller flap can be done based on the lower posterior tibial artery perforator.
Posterior tibial artery perforator. But the
Yes.
posterior tibial artery perforator, usually you expect how many centimeters away from superiorly from the medial malleolus? Usually the perforator over which the flap would be based, would be propelled, is usually how many centimeters superior to the medial malleolus? Usually
5 to 9, 5 to 8 centimeters.
So why not go for the perforator flap? Why straight we go for the anterolateral thigh flap? Why was your choice anterolateral? That is perfectly right. But why do you want to do ALT free flap? Why not fasciocutaneous perforator based flap?
There are chances that the trauma zone may extend into that area and might have damaged the perforators. So it's better to go for a free flap.
But then you would like to see the perforator first with the Doppler.
Sure, and then decide.
And then only you'll go ahead. Okay. Why do you want to go for the fasciocutaneous flap and not for the vascularized free muscle flap?
Muscle flaps, they tend to adhere to the floor of the wound, and if secondary procedure, it will be difficult to raise the flap. So this patient probably will need a secondary reconstruction of the bone. So it will be better to put a fasciocutaneous flap so that orthopedic can raise it and do secondary procedures.
Done, ma'am.
Ma'am, we will move to the.
Sir, I have a question for the
Sir.
paper setter. I have a question.
Please,
Hello.
please.
Is this a single leg or these are two different legs?
It's a single leg only, sir.
And the upper two images are medial view and the lower two are lateral
Yeah,
view?
yeah. Mirror image was made so that they can visualize the all circumferences.
Lower not very edematous.
I understand, but if the upper two are medial views, then that is the right leg. If lower views are the lateral views, then that is the left leg.
Yeah.
Oh no, sir.
Yes, the lower two are, if it is the lateral view, it is the left leg. The upper two are the right legs.
No, images are made.
In mirror image, they will reverse, ma'am, right?
They can reverse, sir.
No. Madam, the reverse images are confusing, no? See, I perceive this as a left leg and I perceive that as a right leg.
No. Just to have the view, they have done the thing like that. It is the same leg, sir. It is from our institute only.
I understand.
Yeah.
All right.
Image was
The other leg is completely normal. Actually, they have to consider the cross leg and all. That
Yes,
also
that is what I was
thought,
thinking, but I
yes,
perceived the upper two as right and the lower two as left.
No,
That is what is
no, sir.
visible, you know.
No, sir.
For the sake of
Usually,
completion.
they last the cross leg also in this type of things. So, other leg is totally normal.
All right.
So, the orthopedic opinion of X-fix and all also required if you
Yes, madam, that
don't
was in my
want to
mind.
do the free
Yes,
flap
madam.
and yes, sir.
The cross leg
For
flap was in my mind.
student's sake, student's sake, I'm telling you.
All right.
For the sake of completion, is there any role for negative pressure wound therapy?
As granulation is appearing from that, we can apply, but if patient needs secondary bony reconstruction, then the graft that we are going to put on the granulation, it won't help. It's better
I
to
just
go
asked for the role, that's all. I didn't ask for the limitation. Fine.
Yeah,
Go ahead.
we have a role to cover the bone degranulation.
See, once you saw the paprika sign, and if there is any contraindication for the major surgery or flap surgery or flap is not available, then you can apply this VAC, native suction, native prostate wound therapy. Once the granulation tissue is covered, including the presently exposed seen bone, you can put a graft until the patient, these things are removed, and then patient starts walking.
Yes, sir.
This is the wound management. Bony management will be done by somebody else. That's
yes,
all.
sir.
If it is a cross-leg flap, how will you do?
Ma'am, we are exceeding the time, ma'am, actually.
Yeah.
Can we move to the
We can
Medially based
cross-leg flap.
For this. For that, we have to realign the external
External
fixator.
I'm
fixator.
just asking, medially based or inferiorly based?
Medially based.
How will it reach? Okay, we'll move on to the next session.
Reach yoga.
Sure. It's also proliferative growth involving the right side of the lower lip and the right side of the lower lip, mostly squamous cell carcinoma of the lower lip. The second question, I will counsel the patient that it has it is a malignancy. It has to be excised, and he will lose his lower latter part of the right part of the lower lip as well as the angle of the mouth. And even after the reconstructive surgery, there are chances that he will have oral incompetence with the drooling of saliva from the angle of mouth. And the options available for this condition is first we'll do oncology team will do wide local excision with 1 centimeter margin, and then we will reconstruct it with the free radial artery forearm flap as it is thin and it can pliable. It is ideal for this condition for this defect. And so stable operative management.
In the pre-op part itself, in the pre-op management itself, we can we'll have to do the Allen's test to check for the patency of the ulnar arch, and then in all oral cancer malignancy patient, we'll also have to do the CT of the face and the to look for any bony involvement, especially of the mandible, and in case it requires resection. And then for if in this case it looks like it only involves the lower lip and no information about the mandible is given, then we can go ahead with the free radial artery forearm flap, and we can we can also take a palmaris longus graft along with it. And then for stepwise
we would like to take a distally based radial forearm flap. And for elevation of the flap, we'll take the
we'll take the ulnar incision first,
and then
according to the size of the defect which has been provided after the oncological resection, we'll mark the defect on the forearm of the patient, the non-dominant forearm, and then we have to start raising the flap from the ulnar side. We go subfacially till we see suprafacially, sorry, till we see
till
the
FCR
lateral border of FCR.
Then we will go subfacially and will
then we go subfacially and then taking the fascia above the FCR, and then we find the pedicle between the FCR and the brachioradialis. Once we visualize the pedicle, then we can go ahead and take our distal incision and the radial incision as well. And distal incision, we'll ligate the
we'll take cephalic vein also in that flap, as well as the radial artery and vena comitatus, and we'll ligate the vessels distally, and we'll elevate the flap distal to proximal.
And
Then
our
this patient will also require a neck dissection. So we'll find a suitable
our pedicle length will
recipient
depend
vessels.
on how much on where do we want to anastomose. So depend.
So mostly recipients vessel will be facial artery or lingual artery, mostly facial artery or lingual artery, and then we harvest a flap and we'll do a reconstruction.
The artery will be facial or lingual, and then vein we can anastomose
with the venicompetentis, or one with the venicompetentis and the other with the cephalic vein. Post-operative care, we ask the patient to post-operatively we have to maintain the position, should avoid the pressure over the anastomotic site, and should prevent the hyperextension of the neck. Also, we have to maintain the hydration and urine output, and also we should avoid unnecessary blood transfusion. Post-op, we have to give anticoagulant like heparin for 48 hours, and we have to monitor the flap. As it is free flap, we have to monitor it every hour for first 24 hours, then
every 2
hourly for next
next 48 to 72 hours, and after that.
And we have to check for the color of the flap, the turbidity, temperature, scratch test, bleeding, and
we can also check for the Doppler signals at the anastomotic site.
And we have to ask patient relatives to keep the mouth clean and prevent the maceration of blood and maintain the oral hygiene. And also have to give oral wash and a follow up.
Follow up if once the flap has settled, then the patient can go for radiotherapy, and after he has finished his sessions of radiotherapy, and if the flap looks most of the times the flap will decrease in size after radiotherapy, but if the patient has any concerns about the flap not being in sync with his lip, then we can go ahead with
secondary
procedures to debulk or thin the flap, and then we can also do the
let's stop over here. I will ask questions from in a reverse manner. Like you said, you are raising distally based radial artery foramen flap.
No, sir.
No, sorry, proximally based.
Proximally based.
Flap will be distal and pedicle
will be proximal.
Okay. So how much would you expect would be the defect after excision? You are excising 1 centimeter or 2 centimeter or 3 centimeter beyond the palpebral lesion?
1 centimeter beyond the indulation.
So can you visualize the defect after excision? How much lip would go, lower lip?
Almost 3/4.
Half of the lower lip will go.
3/4, sir.
3/4.
It will go beyond half of the lower lip.
Beyond the half.
And the cheek area beyond the angle of the mouth, will it go superiorly also?
Yes, sir. As visible in the photo, there is some induration in the.
So it's a very difficult reconstruction because you have to recreate the lining and the cover of the lower lip, and then go beyond the angle of the mouth, resurface the lining and cover up the cheek. It's a difficult three-dimensional reconstruction. That is one. Along with the excision, what about the lymph nodes?
Patient has to undergo modified radical neck dissection, mostly bilaterally, because it is involving the it is crossing the middle of the lower lip. So we'll undergo parietal modified neck dissection, or right-sided modified neck dissection and left-sided selective.
Supposing there are multiple lymph nodes on the right side and no lymph node on the left side, you will still go for the lymph node dissection on the left side?
If it is crossing
yes,
the
we'll go
midline,
for a selective.
That means we'll only do supraomohyoid
lymph node dissection on left side.
So you're going modified neck dissection on the right side, and supraomohyoid is also modified neck dissection?
Yeah, it is selective neck dissection.
and you're taking radial artery forearm flap. And the,
Yeah,
and the donor vessels would be artery and the vein. Artery, you said facial artery?
If facial or lingual artery, depending
If
upon
they
the
have preserved, that is.
So artery would be either facial or lingual artery. And what about the vein?
any branch of interjugular vein. If
Interjugular
no vein is available, then we will do end-to-side anastomosis to interjugular.
Usually, which vein you prefer to do anastomosis with?
We prefer, if common facial vein is there, then we'll prefer.
Common facial vein is draining into?
It will drain into common facial vein, drain into
This.
It will drain into internal jugular that you are saving. So you will be using common facial for the venous anastomosis, facial or lingual. Lingual is very deep inside. It is difficult to find out. One second, this length is very short. Why not superior thyroid artery?
Yeah, we can do anastomosis with the superior thyroid also.
Facial
But
artery is there, but because
pedicle will be
lateral view of the patient, maybe going right up to the facial, and if you are taking out the submandibular gland also, maybe you won't get the length of the facial artery also. So maybe we'll go for the superior thyroid artery, or sometime, as you rightly mentioned, for the lingual artery.
Yes, sir.
And the leg is going to sag all the time because there are no muscle continuity. So you're going for the second stage. Or at the same time, you are doing something for the competence of the leg.
We can use palmaris longus tendon to
maintain
provide
the
some
competency of the leg.
And then you are going for debulking later on.
No, later on we will not do debulking. It's already thin flap. It won't be debulking.
After radiotherapy, it will shrink like anything. It is going to appear like a graft after radiotherapy. The radial artery is very thin flap, and after radiotherapy, it looks like a graft over there. It shrinks like anything.
Yes, sir.
Yes, sir.
Have you ever thought that it can be involving the mandible also, because it's an extensive lesion, and if it is close to the sulcus or sitting right over the mandible, are you going to excise the mandible also?
If it is within the 1
1
centimeter of the outer cortex, then I will do marginal.
Supposing mandible is also involved, will the plan change now?
Then yes, sir. Then we'll do osteocutanous flap for the coverage.
Which osteophacial flap?
Mostly prefibular flap, sir.
Prefibular flap. From the right side or left side? Or any side?
From any side. Mostly nowadays we prefer non-dominant leg for the prefibular harvest.
And how are you going to make lining and cover both with the skin which is lying with the fibula? Are you going to island that, or are you going to deep slice? How are you going to make it?
Sir, we can
we'll take a two islands
based on the perforator of the peroneal artery, and use
one for inner lining and
one for cover.
Yeah, Dr. Parvati would like to ask questions.
Already we have exceeded the time, sir. Can we move to the next section?
Yeah, that's how would you like to ask questions, Dr. Parvati?
Any local flap, regional flap options?
We can try transverse foral flap.
It is one option. Yeah. We can go ahead with the next.
So this is a left hand. For documentation purposes, I would like to mention the level of the amputation of the thumb
and the
middle finger as well as the ring finger. So for the thumb, there is a amputation at the level of mostly MCPJ with a 3 to 4 centimeter wound and expose the head of the first metacarpal. And for middle finger, there is a fingertip injury involving the distal phalanx, mostly Allen's type 3. And for ring finger, there also fingertip amputation at the mid portion of the distal phalanx, Allen's type 3.
And since it is a dog bite injury, we have
So we have to advise vaccination and immunoglobulin on paper. And we have to do first, we have to get the medical legal documentation of the case.
and we get X-ray for the
X-ray of the hand. Later on, we will investigate the patient. We will send the blood investigation and the viral markers. And later on, we proceed with the further management.
This is only documentation, basically. Looking at the thumb, do you think it is exposed to metacarpal or
could be the base of the proximal phalanx also?
Yeah, it won't be metacarpal. And other two fingers, you are talking only about amputation. You have to describe the component of skin involvement also.
Okay.
How do you describe it? You have
it is
to, yeah.
Fingertip amputation with the loss of volar skin of the middle finger till the 2 to 5 centimeter from the distal volar crease. And for ring finger, it is amputation with the hardly 2 mm skin left on the volar aspect till the distal phalanx crease.
Is the pulp tissue?
Can you complete description from one view?
No, sir. We'll have to see the dorsal aspect also.
To say the nail bed
and the remaining dorsal skin.
How do you describe without that? We don't have the picture.
It is difficult then to describe the complete injury.
You tell that if it is not available, I need this also. That's all. Okay.
Is the pulp tissue still there? Is it the pulp tissue lost?
There is loss of pulp tissue in the ring finger, and in middle finger there is part of the pulp tissue is there.
How do you describe that wound?
It's oblique.
Is it thickness loss, or is what component of the pulp is lost?
Ma'am, didn't get your question.
Is the full thickness pulp lost, or is it only the skin avulsion? That is what is my question.
Middle finger.
This is documentation.
Middle finger, it is
full thickness.
Tip of the finger is gone, but in the rest of the pulp, the skin avulsion is there. Similarly, in the ring finger, it is volar oblique injury. I mean, because the dorsal part is seems to be remaining more than the volar part, and so there is associated skin avulsion and the loss of bone.
Tell again about ring finger. Tell again.
Sir, it seems to be an oblique injury in this view, but I would like to have a lateral view to see whether it is
like a gelatin.
Yes, sir.
Looks like a gelatin with a mild sloping.
Mild sloping towards volar side.
Is it a simple injury or grievous injury?
It's a grievous injury.
With the middle finger, you are telling amputation only, but you have to describe. But there is an amputation of tip of finger with avulsion of skin component of the pulp on the radial aspect. Complete description is you have to give.
Okay.
What else you want to
You
ask?
have to describe. We have to describe bone. You have to whatever you can describe bone, nail, direction, different directions. What are the tissues lost? All these things you have to document. Go ahead, madam.
Yeah.
The other thing which we can ask is if the patient have got their amputated parts. especially for
It has to be mentioned
it
in
has
the
to be mentioned if they have gotten and in the condition that they have gotten the parts and in what manner have they transported
within how many
and
minutes.
within how many minutes has
Time
the
of injury also has to be mentioned.
patient presented to our center.
Yeah, what is that called?
Sorry, sir.
There is a name for that. From the amputation to reconstruction.
Warm ischemia time, sir.
Ischemia time.
If they have gotten it, warm
Yeah,
ischemia.
go ahead. Good.
And
What cause of the injury?
It's a dog bite.
Dog bite injury,
as
ma'am,
per
as
the
mentioned.
That also you have to mention. Okay.
What will you write? You will directly write dog bite, or will you write some other word before that?
Whether it is a provoked dog or unprovoked dog, whether the dog
Alleged
history of dog bite with provoked or unprovoked dog.
Whether the dog has been vaccinated or not, and if it is household or stray dog. You have to mention all those things in the history. And we have to concentrate regarding vaccination schedule and the need for ARV vaccine, immunoglobulin.
When you will close the injury?
Sorry, sir?
Yes, sir.
When you will close the injury in a dog bite?
So now we can close it
immediately after giving thorough wash and immunoglobulin, local immunoglobulin.
Any inputs from faculty?
Sir, I didn't get the.
Any inputs from faculty? All agree with immediate closure in the dog bite?
Yeah, we can do the debridement, local injection, infiltration of immunoglobulins, and we can go ahead with the surgery, sir. That is what we follow.
Not immediately, we have to do all these things one by one.
Yes, sir.
Yeah, okay, agreed. Go ahead.
Facial injuries, definitely immediate closure is recommended. And the wounds which require repeated procedures, and in this type of wounds, you can do in a staged wise, and after completing the vaccinations also, you can do the reconstructive procedures.
That is what I am taught.
Yes, sir.
I want to add up here.
And in facial injuries, definitely after immunoglobulin injection, the closure can be done. So what we are following also in our institute, the same way.
Actually, I want to add, we get the very large number of patients of the dog bites in only any part of the body, especially children. And after consulting many papers and with the help of our community medicine people, we have devised the protocol. Except for the face, we are waiting for 72 hours. And we are giving the regular wash again and again for the reconstruction in the hands, legs, and other parts of the body. And for the face, we are doing the immediate repair as required. So we are following this for the last 5-7 years now. And we have the largest series of the dog bites. This time also one of the projects is going on in our department for the craniofacial injuries of the dog bites. And we'll see what the results will come. That's it.
This is the take-home message I want the trainees to take. Thank you.
Thank you.
So documentation involves the description of the wound, the counseling part, and plan of your action. I think that is the idea of this slide.
Options given
You have
also.
to document, yeah. What
Medical legally very important.
Yeah.
Medical legally it is very important.
So all those things to be documented.
And you have to tell the options for the condition to the patient attenders, and their preference need to be taken, and that also you have to document.
Ideally, documentation, these options and all, their benefits and drawbacks, or time taken, whatever it is, these are to be, if possible, whenever possible, to be documented in the patient's handwriting and to be countersigned by an unrelated third party.
Witness.
Witness.
Yes, witness.
Charles,
A witness can be your staff nurse. She is not
Yes.
related to you. She is not related to the patient.
Yes,
Yes,
sir.
sir.
There are 4 signs should be there: patient sign, relative sign, witness, and doctor sign on the paper.
If you can do that, that is the best.
Yes, sir.
This completes all the sessions for today's program. So any questions from panelists or like senior faculty in the audience? Otherwise,
I think we have not
panelists.
discussed. We have not discussed reconstruction of the thumb. How are they going to reconstruct it later on?
I prefer to do that.
Yeah, if
get it done.
You can answer the options you didn't mention.
Yes.
if patient brings the amputated part and it is within the normal, it is well preserved and it is in a good condition, then we can try for replantation as the MCPJ and the CMCJ joint is unaffected. So replantation will give a good result. And if the thumb is not there, then we will try to close this stump by shortening, and we can do local flap like dorsal metacarpal artery flap and FDMA flap. And if after that we can plan for composite thumb reconstruction using first we will give a we can do groin flap.
I'll stop it over here. If you're going to shorten it, then it can very well be grafted. Why do you want to mutilate the dorsum of the hand with the first dorsal metacarpal artery flap?
So
if
you
you're
want-
planning a definite reconstruction later on and you're going to shorten it, why do you want to cover it with the flap?
If
The bone has been shortened, it can very well take the graft also.
Yes, it appears to be from the proximal part of the proximal phalanx. The MCPG joint, if it is normal, then I would like to preserve it, and we have to
So
keep
you are not shortening. You told me you're shortening. So you're not shortening.
debridement of the open part, and then we'll give a local flap cover. If it is involving the MCPG, then I will remove that part of the proximal phalanx. We close it and we'll put a graft, and later on we'll do the reconstruction.
So, and the reconstruction options would be in order of choice.
In order of choice, first.
You can give her the option of toe to thumb transfer. For that, we need to have a good stable soft tissue cover over the stump of the thumb. Therefore, we'll have to give flap cover in the first stage. And does not agree
in this patient also you need a flap cover in the first stage.
So if we are planning for toe to thumb transfer in the second stage, then it is good if we have a stable flap cover.
Okay.
And then, but if the patient, we counsel the patient regarding this, but if that means after this has healed, but if the patient does not agree for the sacrifice of her toe, then we can give her the other option of composite reconstruction of the thumb using bone
graft with the groin flap
coverage.
Okay. So you tell me something about wraparound flap. You've heard about wraparound flap? Because the toe, if you're transferring the toe, it is too bulky and thick as compared to the normal thumb.
Mm-hmm.
So can you go for a trim toe flap or wraparound flap, or it is not possible in this patient because there is no indication for wraparound? Or can we go for the second toe?
Wraparound flap is we take a part of phalanx of the toe and some part of the soft tissue, and we'll wrap it around that.
Phalanx of the toe. Toe has two phalanx. You take one and a half, two, and how much skin and subsequent tissue and tendons? Anyway, we'll discuss it sometime. Please go and read about wraparound trim toe flaps, which can also be asked in the examination.
Split the phalanx, I think. Split the phalanx.
Split phalanx.
Also,
ma'am,
fingertip
that's all from my
injuries
side. That's all
fingertip
from my
injuries is a very big topic. You have to learn thoroughly.
Yeah.
It's one of the commonest in practice also.
So that's all from my side, ma'am. Any other panelists, if anyone wants to ask question?
Well, can I have a question?
Yes, sir.
You have narrated nicely, but it is very short time. Within the time limit, we have to ask questions. So also the answers has to be. So in this case of, you told about replantation. So in replantation, what is the time period? Do you understand what is a warm ischemia, what is a cold ischemia? So in a thumb transplant, what will be the time after which you will discard, no, I will not do a replant?
For digit, as there is no muscle, warm ischemia time is 12 hours and cold ischemia time is 24 hours.
Yeah, very good. Second point, why not you do it? Suppose you don't get the amputated part. Can you not go for a osteoplastic reconstruction?
Yeah, that's what we were talking about. We'll give a groin flap and then we'll put a electress graft in that.
So that can be done immediately. Or else what you can do, wrap around flap, Saras told very nicely. So that is by Gail Morrison from Australia, Melbourne. So sparing the great toe, a part of it can be taken for a reconstruction of the thumb later on.
Yes.
So I think that is a good option later on. But however, second toe, can it be taken in this case or not? As a secondary reconstruction.
The length.
I don't think there is any issue about doing a second toe transfer.
Can be taken.
Yeah.
It can be taken.
So anyway, you have to go through that book, Graham Reed's Reconstruction of Thumb. There is a monogram on Graham Reed, and his classification is very much there with. So I think that type of monogram books, if you read, then you have a clear conception about the particular subject, disease, and also its management from A to Z. And some recent journals also can help you in making possible so that you will have a different type of examiners. Sometime old, sometime medium, sometime also young examiners. So everybody is free to ask about details of recent things in the subject. So I think you as a student, you should be abreast to it, all the past, present, and also the future, what things are going to happen in recent advances. Thank you very much.
Thank you, sir.
Just for coverage sake, how do you advise the patient to bring the amputated part?
It has to be washed with the available tap water. Then it has to be wrapped in a gauze piece, and you have to keep that gauze piece into a plastic sheet.
Wet gauze piece, wet or dry?
Wet gauze piece. And that plastic bag, it should be kept in a bag containing the ice. The part should not be in a direct contact with the ice.
Perfect. Anybody else? Dr. Lakshmi, can I?
Yeah.
Yeah, a little comment from general.
Yes, sir.
The performance by the presenting batch is excellent. One of the best. Congratulations. Number one.
Thank you, sir.
Number two is this is the one which we discussed yesterday. Today, I'm very happy to see most of the displayed things are having names. Yesterday, we were talking to numbers and which sort of gadget it is. Today, it is improved. I don't know whether, how much effort they have put, Lakshmi and Rohit. But still, now one more suggestion I want to make is, while instructing, personally, instructing them, you can tell the person who is talking, even in any position, let them unmute both audio and video also. And then they can mute again. So let us see who is talking, whom we are talking to. That's my point. Over. Thank you all.
Thank you, sir. Now we completed all the sessions. I invite the panelists one by one. Just give the analysis of the PG's performance, and unanswered questions can be explained, and your opinion about Plastiquest and suggestions to improve. I invite Dr. Bandari, sir.
I believe the session has been very nice. The students were very good, but they need to improve in telling the things in clear terms, slow, clear, and loud, so that the message is gone across clearly. Otherwise, they have been good, they know the subject, but the explanation can be a little better, in a better way. The words needs to be clear, slow, loud, and clear. Otherwise, they were good. They had knowledge about the subject.
Thank you, sir.
Thank you, sir.
And one at a time.
One at a time.
Yes, sir.
Thank you, sir. Would you like to share anything from your journey in plastic surgery, reaching to this highest level and becoming almost father of ear reconstruction, especially microtia and burn ear reconstruction?
Ma'am, I've done my MCS.
Which will be inspiring to all young generation to take up this ear reconstruction, sir.
I did my MCS way back in 1987 from Southern Hospital under Dr. S.T. Bajaj. And one thing he would always tell us, please ask questions, anything you feel like, because that will improve the things. One, and second, he used to say, if anybody on this earth can do something, why can't we?
Yes, sir.
See, if somebody can do ear reconstruction or rhinoplasty, why can't we do it? Maybe he can do it reading once, we'll read 10 times. Even if we have not seen it, if you go through the literature word by word, try to understand everything, you'll be able to do it. Maybe it will take time. The curve would be very long, but you'll be able to do it, but it will be solid foundation. So I always understand that if you have to do a rhinoplasty, you have to be very thorough about the anatomy, then analysis. Then only you can understand the ins and outs of the rhinoplasty. Similarly, in ear reconstruction, Dr. Bajaj has started ear reconstruction, but it was not very frequent. We would started with the partial ear reconstruction. And those days, most of the time, ear reconstructions were not taken in. But taken clue from my teacher, Dr. Bajaj, I thought we'll start ear reconstruction, reading all articles, all books, and start with the partial ear reconstruction. And of course, it will take time. But as of now, there are so many people around who are doing ear reconstruction. The YouTubes are available. You can even go and directly understand and work under the people who are doing only a reconstruction or rhinoplasty, but that time it was not available. We didn't have YouTubes or videos were not available. So it was a very difficult time that time. But now if you are actually willing, you can go to the people. Anybody can come to me and learn rhinoplasty or ear reconstruction. Can go to other people who are doing very good work in rhinoplasty. So things have changed. But what is required is passion to understand, to do and excel every time. If you are doing ear lobule repair, next time it should be better. That is what I understand. So next time the stitches has to be good so that there should be tactile namaskar. Even in ear lobe repair, every time you should improve. And that should be a passion. That is the only thing I want to tell.
So what are the differences you found? Like everybody knows some reconstructing burnt ear is very difficult. So would you like to contribute little more about it, sir?
I mean, the difficult being because temporoparietal fascial flap, when I started my raising, it took me 4 hours to raise a temporoparietal fascial flap. As of now, I will take 1 hour. So it is practice makes the man perfect, and you have a passion to find out the difficulties. And every time when you are making your videos, and then you see your videos, you will understand the problems you are facing. And if you're not liking your videos of dissection or raising the flap, that means there is somewhere something is lacking. So I always try to make my videos and try to analyze everything ins and out, every piece, every minute, where I'm liking, where is the problem in the dissection, and then I try to improve. And then I will take input from everyone, from my students, from my anesthetists, and anybody around. अगर उनको मजा नहीं आ रहा, that means there is some problem. If they're enjoying surgery, that means you're actually doing good surgery. So that is what I want to take inputs from everyone. Read articles every time when you're going to do the surgery, because if you read the article again and again, you'll find newer things. Even if you've done hundreds of cases, if you do rhinoplasty, read again, you'll find newer things, because you understand the things well after you've done the surgery, because you now understand the problems, and then you find the solution of the problem in the same article. So every time I go for a ear reconstruction, even today, every time I go for rhinoplasty, I again go through the books, and every time I found something new. So my advice to youngsters would be, it is good to see a person operating, but please read everything, every steps about the procedure before actually seeing someone doing executing this surgery, because only seeing is not good. Understanding the surgery ins and out, anatomy, surgical steps, and then seeing would make you perfect. Thank you, madam.
Thank you, sir.
Bandari sir.
Sir.
I want to learn something, a few words about tissue expanders in burnt ear reconstruction.
Really, you snatched my question, sir.
You know, I've written an article. If there is a scar which can be stretched, then you can put in a tissue expander. So I have done in few cases, but in some of the cases, when you start expanding at one time, it breaks open. The scar will give way. And then you are at loss because 2-3 months are wasted. One stage is also already done. So unless it is a very superficial scar, which you believe after expansion will withstand the pressure of tissue expander. Otherwise, if you have a post-bun deformity, it is better to go for a temporoparietal facial flap. In spite of the flap, the color match is not good. But temporoparietal facial flap will be the choice for post-bun ear deformity.
Thank you, sir.
Thank you, sir. I invite Dr. Uday Bhatt, sir, to
Yeah,
give
good
your
evening, madam.
inputs.
Yeah. First of all, thank you very much for inviting me here. And secondly, I agree with Dr. Bhandari, sir, that both the students have performed really well. But having knowledge is one thing, and expressing it and putting it across to the examiner, that is one other thing. Most examiners don't like something expressed in broken sentences. So don't use broken sentences. Your sentences have to be complete. And
Yes,
always begin your sentences with your answer with sir or madam. Sir, this is what I think. Or madam, this is what I think. That shows that you are involved and you are directly communicating with the examiner, so that involvement has to be there. You are not aloof, you are part of the thing, So that is the only area where they can improve, but otherwise they have performed really well. Thanks so much.
Thank you, sir.
Thank you, sir. Any experiences you would like to share with us?
Not really. Because I practice, I am not in private practice. I am in a municipal
Government, sir.
hospital, government hospital. And experiences in government hospitals and private practice. Private practice is a different ball game, So what requires in private practice, I really can't, tell the people. Because we have a lot of resources and we have everything available in this thing. We have manpower, we have dressing material, we have everything, We don't have to really think about, economy, about finances. So I really don't know, about private practice. It is a different ball game. So that they really need to learn how to practice and, how to survive all this.
No, I've seen both. Practice is a different word.
Yes.
I invite Dr. Parag, sir, to give your inputs and
Just
your
1 second.
journey and experience.
1 second, Dr. Parag. I just want to convey one point, useful point to the PGs for the examinations. If you don't understand the examiner's question, don't imagine and then proceed to answer. Nobody will penalize you if you ask, I didn't understand, sir. Can you please ask again? Like that, please ask. Make sure what the examiner is asking and answer. Sorry for the interruption. Please go ahead, Dr. Parag.
Thank you, sir. I think I agree with Uday Bhatt sir and Padam Bhandari sir that both the students did really well in today's cases, and I wish them best of luck for their upcoming exams. Only 2-3 suggestions. Read recent advances in different aspects of plastic surgery. You may either get a short note or you may get some questions during your viva about some recent advances. To learn to make patterns, especially when you're talking about leg defects or any other reconstruction, keep the habit of making patterns, because some examiners are going to ask you to make a pattern, and unless you have practiced, you may fall short of time during your practical exams if you don't have the habit of making patterns. So learn how to make good patterns of the defects, how to create different three-dimensional patterns if you need. And basically stick to practical aspects, whatever you're seen during your residency, that would serve you in good stead. And as in today's discussion on microtia, for example, when you said that you have only seen Brent technique and that's why you opted for Brent technique, nobody is going to penalize you. So stick to whatever you actually seen during residency, because what the examiners would want to know from you are the practical aspects of how you would treat a patient as if actually you are in front of a patient. So don't go just by the theoretical knowledge. See and apply the practical aspects, whatever you've seen during your residency, and I'm sure you'll do well in your exams.
Thank you, sir.
Your experience and journey in plastic surgery journey and ear reconstruction, your during your stay at France. So anything you would like to share?
I would
And
say
success in ear reconstruction.
I would say I was lucky to get a chance to work with Dr. Françoise Firmin. I feel she was one of the most phenomenal surgeons I've seen operate. So the way she used to handle the instruments, the way she used to suture, I learned a lot of things from her, not only in ear reconstruction, but also in all aspects of plastic surgery and even surgery, I would say. And she had a very great sense of clinical aspects of ear reconstruction. So she would always have a plan B or a plan C ready in case the plan A was not successful. And I think that is what makes a great clinician. So yeah, I was lucky to have the chance to train with her, and I try to implement her teachings in my ear reconstructions.
Thank you, sir.
One question to Dr. Parag. Dr. Parag, do they have any discounted accommodation facility?
In Paris?
Yes.
In Paris? No, sir. In Dr. Françoise Firmin has now retired. When I was there, we had to search for our accommodation on our own. They were not.
Okay. Done. Thank you.
I invite Dr. Parvati to.
Dr. Lakshmi, thank you very much for inviting me for this Plastiquest competition. It's a short notice, but I could manage. Regarding the performance of students, they have done very well with the case microtia. But rest of the things, I think they have to practice more. My suggestion is, apart from clinical case discussions, I think they should start doing the imaging and operative sessions also during their academic sessions. That will improve their viva performance during the examination. They are knowledgeable, but they are not able to express thoroughly. So that is one suggestion. Apart from clinical case discussions, they should also concentrate on these things: imaging, surgical procedures and all those things.
Thank you, ma'am.
Thank you, ma'am.
Thank you.
Actually, the case was selected by them from their institute, and all other sessions spot given.
Yeah, I know.
So yeah,
That's why,
just like
unless
we
they
want
start,
to keep that exam pattern, so they don't know anything about the other sessions.
yeah, that's why I'm
In
telling like it should
yeah,
also be a practice of regular academic
yes,
sessions. I
yeah,
think we just started this way. I think that will benefit the final year students when they speak in Viva during Viva.
yeah. And
Examination
would
will
you
be done
like?
like that only.
Yeah,
Examination
yeah. That is
will
the
be reviewed
reason
then and there.
we planned the sessions exactly to mimic the exams. We kept the time as well as everything spot we have given. And anything you would like to share from your journey and experience?
I did my post-graduation from Nizam's Institute under Dr. Mukund Reddy sir. Sir used to do a lot of microshare reconstructions. From there, I learned, pick the principles and skills and tricks and all those things. And it is not one particular technique that we keep following it. As you go on, I mean, when you travel your journey, you learn so many things. You start picking up things and on your based on your own experiences and looking at your seniors and experts, then you change your modifications. I'm still in the process of learning. So and there is a lot of improvement from my microshare reconstructions when I started and now I keep adopting many principles from different persons, Brent, Nagata, Fermin. So we keep adding different